Preface O. We chose to edit this book because we believed that it would benefit readers in several ways. First, as clinical psychologists ourselves, we are deeply concerned about the large number of professional psychological services sold and delivered that are not evidence-based. This is a preventable tragedy that often harms the very people we ought to be helping. Regrettably, too little is done by our professional organizations to call attention to this problem and to remediate it. Certain professional organizations in particular are complicit in this benign neglect, prioritizing the interests of dues-paying members who wish to practice their favored interventions and administer their favored assessment instruments over the interests of clients. By illustrating how evidence-based approaches can be put into practice, we hope that this book will increase the likelihood that current and future practitioners will deliver them. Second, we want to highlight the wide variety of evidence-based assessments and interventions available to clinicians. The stimulating chapters that follow depict exposure therapies, skills-building interventions, contingency management, behavioral activation, and cognitive interventions, among others, for a broad array of clinical presentations. Clinicians and students ought to find this diversity both interesting and challenging to master. Third, we hope to underscore the complexity and richness of clinical cases. Following the evidence is not a mechanical or cookie-cutter process, as each case is unique and has its own complexities. This canard is commonly expressed by the critiques of evidence-based interventions. I don't want to follow a boring manual. I want to think and make judgments. The cases that follow demonstrate that sophisticated clinicians implementing evidence-based treatments make numerous individual judgments, with great care and forethought, decisions that are nonetheless guided and constrained by scientific evidence. As such, evidence-based practice is in no way akin to following a cookbook. The case studies in this book nicely illustrate what Temple University psychologist Philip Kendall has termed flexibility within fidelity, using evidence-based treatment protocols as rough blueprints to be modified as necessary. We should be clear that we are not presenting these cases as further evidence to support the claims of specify C therapy's efficacy or effectiveness. This error has been a common one in our Phi ELD. The question, does therapy X work, is all too often answered in the affirmative, solely by a case example, well, this treatment seemed to work for my client, so it must be effective in general. This is not the purpose of the cases that follow. Nevertheless, we believe that these cases can serve as exemplars for clinicians to learn from and apply to their own cases. In the psychotherapy outcome literature, actual cases are typically presented without 12. Preface. Much detail and are described only in the most abstract fashion. The chapters that follow enable clinician and student alike to observe stand the meaty details of evidence-based treatments and assessment procedures. In addition, they permit them to see leading psychotherapy researchers apply these techniques skillfully to their own areas of expertise. This book should be of interest to a number of audiences. Practicing clinicians, clinical researchers, and students in training in all mental health professions, clinical psychology, social work, counseling, psychiatry, psychiatric nursing will benefit from the cases and the stimulating back and forth discussions of treatment and assessment approaches presented here. In addition, instructors in clinical psychology, psychotherapy, and abnormal psychology at both the graduate and advanced undergraduate levels should find this book to be a valuable supplement to their other texts. We would like to thank a number of individuals for their assistance with this book. We would like to thank Linda Goddard and Olga Saluja for their help in the preparation of the manuscript. In addition, we thank our editor Sarah Harrington at Oxford University Press for her expertise, guidance, and patience with us during this project. Finally, we thank the clients whose courageous struggles comprise these clinical cases and whose life stories here inform, and we hope, will ultimately help future clients. Jonathan S. Abramovitz University of North Carolina at Chapel Hill Lauren B. Alloy Temple University Kevin M. Ansel Suni, Upstate Medical University Russell A. Berkeley Medical University of South Carolina, Charleston Judith V. Becker University of Arizona Deborah C. Baydell University of Central Florida Alan S. Bell Lack University of Maryland School of Medicine Richard A. Bryant University of New South Wales Natalie Castriota University of California Los Angeles, UCLA, Jep Coletti Binghamton University, SUNY, Michael T. Compton the George Washington University School of Medicine and Health Sciences Liam Condon Binghamton University, SUNY, W. Edward Craighead Emory University Julia R. Craner University of Maine Michelle Krask University of California Los Angeles, UCLA, Barbara Kubik Eastern Virginia Medical School Melanie Duckworth University of Nevada, Reno Bodai W. Dunlop. Emory University. Sheila M. Aberg University of Florida Jane E. Fisher University of Nevada, Reno Patrick C. Fryman Boys Town and the University of Nebraska School of Medicine Alan E. Frazzetti University of Nevada, Reno Christina Garrisondine University of Nevada, Reno Robert Gatchell the University of Texas at Arlington Nika R. George University of Missouri St. Louis Ashley E. Greenwald University of Nevada, Reno Robbie Haggard University of Texas at Arlington. Contributors O. 14. PATRICIAJ. ROBINSON. Contributors. Deborah A. Hope. UNIVERSITYOFNEBRASKA, Lincoln. Michael E. Kelly. University of Nebraska's Monroe Maya Institute Stephen J. Lynn BIN GHAMTONUNIVERSITY SUNY BRITT AINMAHAFFEY. University of North Carolina at Chapel Hill Richard M. McFall Indiana University, Bloomington Belinda McIntosh. Emory University School of Medicine Harold Merkelbach MAAST RICHTUNIVERSITYANJANAM URALIDHARANEMORYUNIVERSITY Angela Nickerson. University of New South Wales AMANDAM. NZI University of Florida, OLGAV, OBRAZTS, OVATEMPLEUNIVERSITY Carol B. Peterson. University of Minnesota Medical School Jeffrey J. Rakowski EMORYUNIVERSITY Shireen L. Risby Rutgers University. Mountain View Consulting Group. Barbara O. Rothbaum. Emory University School of Medicine. CLAIRRUMMEL. University of Nevada, Reno. Crystalline Salters Pednialt. Eastern Connecticut State University. Holly A. Senyuk. University of Nevada, Reno. STACYSHAW. BOYSTOWN. SANDRAT. SIGMON. University of Maine. Ann M. Stephan. University of Missouri St. Louis. Jill D. Stinson. Fulton State Hospital. Milena Stoyanova University of Nebraska, Lincoln GEOFFREYL. THORP University of Maine TO, NYWA, RDD EAK, INUNIV ERSITYW. LARRYWILLIAMS. University of Nevada, Reno K. LIRAYOONUNIV ERSITYOFMAINE. TRODUCTION. Case Formulation and Clinical Science. William O'Donoghue and SCOTTO. LILIENFELD. For a case to be conducted within the paradigm of clinical science, it FIRST must be formulated along scientific C lines. The essence of a scientific C approach is the ceaseless effort to compensate for confirmation bias, the ubiquitous tendency to seek out evidence consistent with our hypotheses and to deny, dismiss, or distort evidence that is not. Lilienfeld, 2010, Popper, 1965. Of course, not all case formulation is scientific C. Freud's case studies, although beautifully written and ingeniously interpreted, made little or no effort to control for confirmation bias and a host of related biases. Lazarus, 1991. To the contrary, Freud often worked hard to find any evidence that might rescue his clinical hypotheses from refutation. Many thoughtful scholars have written about case formulations, e.g., Haynes O'Brien and Carhollo-Kula, 2011, Nezu, Maguth, and Lombardo, 2004, Persons, 2008, and these useful analyses have often adopted a cognitive behavioral orientation, which would seem at least prima facie scientific C. Although we believe that these authors offer many valuable insights and helpful practical suggestions, they leave unanswered a host of questions about the fundamentals of scientific C case formulations. These core questions include the following. How do we define the key dimensions of the problem of case formulation? What does it actually mean to formulate a clinical case along scientific C lines? What makes a case formulation scientific C, as opposed to unscientific C? What are the advantages and disadvantages, if any, of a scientific C case formulation? Can a scientific C case formulation be a matter of degree, so that a case formulation can be a little bit scientific C, or a lot? Are there any legitimate competitors to a scientific C case formulation? Can there be more than one sound scientific C case formulation for a given case? In this introduction, we address these and other often unasked questions about case formulations. Proper case formulation is crucial, as case formulation provides the blueprint and foundation for the professional's behavior. This behavior, in turn, bears direct implications for whether the client's problem will be correctly diagnosed, properly and efficiently understood, and safely, effectively, and 16. Introduction. Efficiently treated. Without a sound case formulation, incorrect treatment goals can be pursued, and incorrect assessment methods, and less effective or safe treatment methods can be administered. In other words, clients, as well as friends and loved ones, can experience needless suffering. Physical medicine has been relatively proactive about defining medical errors and taking systematic steps to reduce them. See, for example, Gawand, 2009. In contrast, those of us in clinical psychology have, to be charitable, displayed an attitude of benign neglect to the problem of errors in our formulations, which can lead to what may be called psychotherapy errors. O'Donoghue and Heaton in preparation. The meta-questions of case formulation. The prominent philosopher of science, Sir Karl Popper, 1965, once asked his students to conduct the following exercise. TWENTY 5 years ago, I tried to bring home this point to a group of physics students in Vienna by beginning a lecture with the following instructions. Take a pencil and paper. Carefully observe, and write down what you have observed. They asked, of course, what I wanted them to observe. Clearly the instruction, observe, is absurd. Observation is always selective. It needs a chosen object, a definite task, an interest, a point of view, a problem. Page 61. The clinician is in a similar epistemic situation. He or she needs a focus, a point of view, to use Popper's words. He or she cannot simply observe and directly see a case formulation. There is no such thing as purely bottom-up, that is, theory-free, observation in psychotherapy, because practitioners inevitably harbor theoretical preconceptions that influence their interpretation of clinical data. Moreover, virtually any piece of clinical data, for example, a client's yawning during a therapist's interpretation of her phobia, can be interpreted in a multitude of ways, including that this behavior is rather insignificant. A properly executed case formulation performs this winnowing function to allow the clinician to acquire a certain cognitive economy. He or she can focus on certain, relevant, important items while ignoring many others. For the clinician can ask about the client's shoe size, history of shoe size, history of shoe buying, the client's parents' shoe sizes and history of shoe buying. The list can go on and on. The key question becomes, of all the possibilities that the clinician can observe, what is the list of legitimate candidates that the clinician ought to observe, and how can they be organized to inform practical behaviors that the clinician ought to pursue? Scientific C research and scientific C theories that have been corroborated by research relative to their competitors, Popper, 1965, are the best candidates for constructing this list. Shoe size ought to be observed if and only if research shows that it helps define a problem, i.e., it is relevant to diagnosis, or helps to understand the cause of problem, i.e., it is relevant to psychopathology, or is relevant to Introduction. 17. Treatment, i.e., it is an important process or outcome variable in psychotherapy. If these relevancies are not found in research, then this construct can be ignored. Perhaps the central mistake in case formulation is to allow favored beliefs, often untested or tested and found to be inferior to other alternatives, to hold sway over assessment and treatment methods that have more scientific support. Lilienfeld, Lin and Law, 2003. Theories can assist clinicians to select dimensions on which to focus, such as dreams, slips in speech, toileting experiences, and castration fears. Other accounts can help clinicians to select such clinical issues as details in one's drawings of a house, or authenticity, or ability to act in a certain way in a psychodrama. Again, one can see myriad possibilities. The thesis of this work is that a scientific approach allows clinicians to rationally winnow these possibilities into a viable focus, one that is in the client's best interests, and in which the therapist's epistemic duties, such as the knowledge of which treatment approaches yield the best outcomes, are best honored. O'Donoghue and Henderson, 1999. At the same time, a scientific approach is self-correcting, so that if the initial focus of the practitioner turns out to be misleading or incorrect, the practitioner should be able to shift to a different, and more clinically useful, focus. More specify Cowley, a sound case formulation answers the following meta-questions. By meta-questions we mean questions about questions, so a meta-question is a higher-level question. We also use the term meta given that the problem is reflexive, information is needed to determine what information is needed. What information ought to be gathered in this case? What decisions do I as a professional need to make in order to determine which courses of action to pursue with this client, and how should I make them? What are the client's problems? How are these best described? What kind of constructs should I use, e.g., major depressive episode, sadness, dry drunk, loss of attachment, Figure? What are the key dimensions of these problems? How long have they been in existence? How severe are they? What are possible causes of these problems? Are these causes interrelated or independent? What are effective ways to treat the client's problems? What are effective ways to prevent relapse? HOWCON phi dentum I in my conclusions about the above and regarding the OLLOWINGQUESTIONS. Contra others who have written on case formulation, Haynes, O'Brien, and Carhollo-Kula, 2011, Nezu, Maguth, and Lombardo, 2004, Persons, 2008, we argue that 1. The form of a scientific case formulation is that of a sound deductive logical argument. This point is critical, although it is missing from other explications of what scientific case formulations are. We agree with Popper. 18. Introduction. 2. 3. 1965, that science is a subspecies of rationality, and that formal logical arguments are the currency of rationality. The premises of the deductive arguments contain responses to key questions of case formulation, see below, and together these premises entail certain conclusions and courses of action. Other explications of case formulation suggest a list of considerations, but these have no formal rational connection. In our account of case formulation, they are premises of a sound deductive argument. In addition, the advantage of such arguments is that they can be explicated, and explicit reasoning increases accountability. Scientific case formulation is complex. There are multiple arguments that need to be formed, each has multiple premises, and the nature of these premises are varied, covering ethical claims, descriptive claims, summaries of research, and so on. There is one major meta-argument, namely, the clinician's formulation of the case, and three component deductive arguments, one covering goals, one assessment methods, one treatment methods. These arguments, in turn, are interrelated. 4. At times, ideology rather than science has influenced case formulation. This is particularly the case with the American Psychological Association's, APA's, fetish with cultural sensitivity, O'Donoghue and Venuto, 2011, and other vague constructs such as professional knowledge, both of which are used in the APA's ethical code. In both cases, the APA is right to imply that culture and professional knowledge need to be investigated by researchers, provided that these researchers can be clear about what constructs they are measuring. But the APA has often implied that far more is understood about the role of culture and professional knowledge in influencing psychotherapy outcome than is actually the case. For example, although virtually all would agree that it is important for therapists to remain attuned to cultural factors in therapy, just as therapists should remain attentive to issues of gender, age, personality, religion, political views, and other variables as they may arise in treatment, there is presently little systematic evidence that tailoring interventions to cultural backgrounds results in improved treatment outcomes. However, the APA has precipitously encoded this ideological commitment into its ethical code, indicating that the clinician needs to focus on these variables, despite the lack of evidence that these are indeed relevant. 5. Scientific case formulation is not a mechanical process, but involves clinical judgment. As such, clinicians need to be on guard against well-known biases and heuristic errors, the latter of which stem from the uncritical use of mental shortcuts, or rules of thumb, Ruscio, 2007, such as illusory correlation, foreseeing statistical associations in their absence, and an over-reliance on the representativeness heuristic, judging a book by its cover, such as assuming that a client, who is similar, in some ways to previous clients, with disorder X necessarily has disorder X. Introduction. 19. 6. Scientific case formulation should take place in the context of systematic quality improvement processes, McFall, 1991, O'Donoghue and Fisher, 2009, namely, processes designed to identify errors in practice and eliminate them, thereby enhancing client care. This is because no case formulation process is without error, and quality improvement seeks to minimize error in the current case as well as in future cases. The last point emphasizes that explicating a case formulation is crucial to holding healthcare professionals accountable. Increased accountability is a central component of healthcare reform efforts. Clinical cases ought to be conducted such that the clinician, and even the client, as part of informed consent, have an explicit understanding of the case formulation and its soundness. It can be problematic if the clinician cannot explicate the case formulation, or if the explication shows faults. In a classic statement of behavior therapy, Ullman, 1977, argued that therapy ought to be data-based and data-generating. Quality improvement is data-generating. Data such as fidelity to treatment manuals, client satisfaction, and magnitude of clinical change can all be collected and compared with benchmarks. McFall, 1991, also argued that quality improvement data should be gathered to understand how the clinician can improve. See O'Donoghue and Fisher. 2009, for a further explication of quality improvement in clinical psychology. WHYSCIENCE. Science is widely believed to be superior to other ways of generating knowledge, such as intuition, for several key reasons. 1. Historically, the scientific C method has by far worked the best. See Lilienfeld and O'Donoghue, 2012, 4 key classic readings regarding this important point. When humans have applied science to problems, we have made the most progress. Prayer, guessing, unsystematic case studies, and the advice of gurus have repeatedly been found to be inferior methods for producing knowledge. When science has been applied to problems, progress has been made. We have cured diseases, put people on the moon, built bridges spanning wide expanses, and gained a deeper understanding of the structure and behavior of the universe. When we have applied science to human behavior, we have also made progress in understanding basic behavioral principles, e.g., learning principles, and in developing applied technologies for ameliorating clinical problems. See the subsequent chapters in this book. Science is intimately involved in error correction. Clinicians, just like everyone else, can and in fact do have erroneous beliefs. Science minimizes confirmation bias and our love of an attachment to our most cherished beliefs by putting them to the test. Popper pointed out that our tests should be severe. By that, he meant that we should attempt to falsify our beliefs, so that if we are wrong we find this out efficiently. It is a more severe test of the belief Frank does not swear to. XX. Introduction. Observe Frank after he hits his thumb with a hammer, or on the golf course, than to view him in the church pew on Sunday morning. In behavioral health care, we can do harm to our clients if we hold false beliefs. If we think test X is valid for measuring a construct, e.g., depression, when it is not, we can come to false conclusions about our client. If we think therapy Y is the most efficient and effective intervention for alleviating our client's problems, when it is not, we can cause them needless suffering. Finally, we agree with McFall, 1991, who argued that there is no viable alternative to science. Science provides us with knowledge that no other method can or has. Intuition, gurus, clinical experience, and interesting narratives may all be useful in some cases as a means of generating intriguing hypotheses that can later be pursued in systematic research. Yet, compared with science, all fall woefully short when it comes to producing enduring knowledge. The key arguments in case formulation. Following O'Donoghue, 1991, we suggest that there are 3 major questions in the typical psychotherapy case. 1. What will be the treatment goals? 2. What assessment methods will be used? And 3. What treatment methods will be used? These will define the major dimensions of the case, as they define the desired goals and process of the case. Formulating treatment goals. There are 2 major ways in which treatment goals are determined. 1. The client decides on these, for example, I want to quit smoking and the therapist agrees this goal is acceptable. Or 2. The clinician decides on them, for example, you are suffering from obsessive-compulsive disorder and you ought to try to change certain behaviors. We will now explicate the deductive arguments that ought to serve as key components of the clinician's case for formulation. Argument 1A. Client-driven treatment goals. 1. Client C wants to achieve state of affairs S. 2. C is informed about alternatives and the costs and benefits associated with achieving S. 3. S is a morally permissible state of affairs. 4. S is a practically feasible state of affairs. 5. S is not inconsistent with any overriding states of affairs that C wants to, or should, obtain. 6. VARIABLESINFLUencing S, or S itself are psychological, or behavioral entities. 7. If 1, 2, 3, 4, 5, 6 and ceteris paribus, all else being equal, then S is an appropriate treatment goal. 8. Ceteris paribus. 9. Therefore S is an appropriate treatment goal. Introduction. Xi argument 1b. Other driven treatment goals. 1. Significant other O wants individual I to be in state of affairs S. 2. I does not want to be in S. 3. Some factor overrides I's desire not to be in S. 4. O is in some legitimate position in relationship to S that allows O to determine treatment goals, e.g., parent, guardian. 5. O is informed concerning alternatives and the costs and benefits associated with achieving S. 6. S is a morally permissible state of affairs. 7. S is a practically feasible end state. 8. S is not inconsistent with any overriding state of affairs that I should obtain. 9. Variables influencing S, or S itself are psychological or behavioral entities. 10. If 1 to 9 and ceteris paribus, then S is an appropriate treatment goal. 11. Ceteris paribus. 12. Therefore S is an appropriate treatment goal. Argument 2. What assessment methods will be used in this case? 1. Therapist T wants information I1. In 2. Information I1. In has been shown in well-designed research studies to be potentially relevant to the treatment of client C. 3. Gathering information I1. In is morally permissible. 4. Gathering information I1. In is practically feasible. 5. Information I1. In is sufficiently complete and comprehensive information about the principal dimensions of the case. 6. Assessment methods A1. And are reliable and valid methods for gathering information I1. In. 7. Assessment methods A1. And are cost-effective methods for gathering information I1. In. 8. C is fully informed regarding alternatives to gathering this information and these assessment methods, and consents to the gathering of this information by the use of these methods. 9. If 1 to 8 and ceteris paribus, then assessment methods A1. And are the Proper assessment methods to use in this case. 10. Ceteris paribus. 11. Therefore assessment methods A1. And are the proper assessment methods to use in this case? Argument 3. What treatment methods should be used in this case? 1. Treatment goal G entails the realization of states of affairs S1. Sn. 2. F1. Fn are all factors that are known through well-designed research to be causally relevant to S1. Sn. 3. F1. Fn are cost-efficient methods to obtain S1. Sn. Xi. Introduction. I. F. 4. F1. FNM are the least restrictive methods to obtain S1. Sn. 5. Client C is fully informed concerning alternative methods and the costs and benefits of these methods, and consents to the use of F1. FNM. 6. 15a and d ceteris paribus, then F1. FNM are the proper treatment methods to use in this case. 7. Ceteris paribus. 8. Therefore F1. FNM are the proper treatment methods to use in this case. In addition, there is one meta-argument that collects these sub-arguments and concludes that all of these cohere into a sound case formulation. The meta-argument, the clinician's case formulation. 1. S is an appropriate treatment goal. 2. Assessment methods AZ. And are the proper assessment methods to use in this case. 3. F1. FNM are the proper treatment methods to use in this case. 4. If appropriate treatment goals have been chosen, if the case has been properly assessed, and if the proper treatment methods have been competently applied, and ceteris paribus, then the client problems should show improvement. 5. Ceteris paribus. 6. THERESPARATIONSHOULDSHOWIMPROVEMENT. Comments on the nature of case formulations. These arguments show that there is a wide variety of different types of information needed to make a complete and sound case formulation. 1. Empirical information concerning specify C facts. For example, the clinician must assess the goals of the client. Argument 1, premise 1. 2. 3. 4. 5. Moral and ethical knowledge. For example, the clinician must decide whether a treatment goal is ethically permissible. Argument 1, premise 3. An example of this is whether changing a homosexual orientation in a client who desires to do so is ethically permissible. Financial information. Costs of assessment methods and treatment methods and alternatives must be considered, for example, in argument 3, premise 5. Causal information. The means to desired ends must be determined, for example, in argument 3, premise 2. Psychometric information. The therapist needs to understand what are valid inferences and what are error terms in various alternative assessment devices, for example, in argument 2, premise 6. Introduction. 23. 6. 7. Pragmatic information. The therapist must determine what is practically possible when informing the client about alternatives, for example, in argument 3, premise 5. Metaphysical claims. The clinician's ontology, what exists, views about meaning, what constitutes a good life, O'Donoghue, Lloyd, and Lavin, in preparation, and what is morally acceptable also influence case FORMULATIONS. STRUCTUREOFTHEBOOK. WHYCASESTUDIES. We are presenting case studies of over a dozen clinical problems not because we believe that they add to the evidence base supporting these assessment and treatment options. We understand the epistemic limitations of case studies. McFall, in Chapter 8 of this volume, nicely summarizes these limitations. For example, case studies are markedly limited in inferring cause and effect relations. In addition, they are often of unclear generalizability to other cases. Moreover, like some published case studies, the cases in this book are often amalgams of several cases, or are partially disguised features, due to concerns regarding confidentiality. So these cases may not always mirror clinical reality precisely. Rather, our purpose in asking authors to present case studies was to illustrate how clinicians can bridge the two great clinical realms of general and the specify C, or what are often termed the nomothetic and the idiographic. One of the practitioner's major challenges is how to translate the results of group studies, such as randomized controlled trials demonstrating a treatment's efficacy, to the idiosyncrasies of the individual case. Well-conceptualized case studies can demonstrate how to apply nomothetically derived knowledge to the idiographics of a specify C individual. In this way, case studies can be similar to what Kuhn, 1970, meant by a paradigm, a problem-solving exemplar that can serve as a model for solving similar problems. The case study by itself certainly is not sufficient to demonstrate causal inferences regarding clinical methods or problem resolution, but at its best it can help to illustrate how one takes a scientifically supported regularity and applies it to a specify C clinical case. Let us illustrate with an example. There are strong regularities regarding electricity. Let's say that an electrician uses such regularities and publishes an article showing how she used them to wire a particularly complicated house. She says, in effect, that given that there is a scientifically established regularity known as Ohm's law, in wiring this hot tub, I needed to increase the width of the wire, and doing so, changed resistance by X amount. Concerns about the overreading of case studies would be correct if the electrician used her wiring experience with the hot tub as the primary kind of evidence to support Ohm's law, or to justify her future behavior regarding wiring. It is the scientifically established regularity, Ohm's law, that provides the warrant for the electricians. Xiv. Introduction. Behavior. But if the electrician cites Ohm's law, and also shows the instantiation of this law in the wiring of the hot tub, she is on reasonable epistemic grounds. In addition, she may instruct other clinicians on how to behave successfully when faced with a practical problem. See Hempel, 1965, regarding law model scientific C explanation. The content and format of the book. In developing this book, we followed a consistent game plan. First, we invited authors who were prominent contributors to the process and outcome literature for a particular clinical problem. We recruited authors who were well acquainted with the relevant research literature and its gaps, as well as informed about real-world complexities of implementing the assessments and treatments. To ensure that the chapters addressed similar clinical questions that often arise in treatment, we asked authors to address the following dimensions in their case description. 1. What are the key principles or core knowledge that you use in initially approaching this case? Explicate principles from basic science. 2. How did you develop an assessment strategy in this particular case? What were key questions that you needed answered, and how did these direct case formulation? What did you rule out and how? What is your view of the psychometric standards, validities, of the assessment strategies that you decided to use? 3. What epidemiological considerations, such as base rates and comorbidity, if any, came to play in diagnosing or case formulation? 4. What was your initial case formulation? How did you come by it, and how is it evidence-based? What diagnostic issues arose, why and how did you handle these? 5. How did you develop an intervention model for this case? What other interventions did you consider and reject, for what reasons? 6. How did you deal with non-specified CS in this case? 7. What were your strategies for dealing with therapy problems, missed appointments, distortions, lack of commitment, etc.? 8. What would you have done if therapy wasn't working like you thought it would? 9. What ethical considerations came into play? 10. What common mistakes did you work to avoid in treatment? 11. How did you deal with relapse prevention and termination? 12. What is the art of this case, and how was it, if at all, informed by scientific evidence? 13. What cultural factors did you consider, and what difference did these make? If relevant in this case. Introduction. XXV. In addition, to show that case conceptualization is not a mechanical process, but that there are legitimate options at several choice points, and that reasonable people could disagree, we asked other leading researchers to review the case study and to provide a brief commentary. In turn, we also afforded the original authors the opportunity to rejoin to this commentary. This lively and thought-provoking three-way interchange, we believe, illustrates the dynamism of the clinical science approach. Some have falsely characterized clinical science as dry and mechanical, such as following a treatment manual in a formulaic way. We are convinced that this is a caricature, and that the interchanges to follow show why. We will see that, although there is often broad consensus on fundamentals, there are interesting disputes, possible fodder for future research, regarding diagnoses, choice of treatment goals, assessment strategies, and research interventions. Such disputes, we contend, ref ECT healthy differences of opinion, which in turn are the lifeblood of scientific progress in clinical science. REFERENCES. GAWANDEA. 2003, Complications, A Surgeon's Notes on an Imperfect Science. New York PICADOR. Haynes, S. N. O'Brien, W. H. and Kaholokula, K. 2011, Behavioral Assessment and Case Formulation. Hoboken, New Jersey, Wiley. HEMPEL, K. 1965. Aspects of Scientific C Explanation. New York, The Free Press. KUHN, T. 1970. The Structure of Scientific C Revolutions. Chicago, University of Chicago Press. L. L. I. ZARUS, A. 1991. APLAGUEO and LITTLEHA and SANDLITTLEALBERT. Psychotherapy, Theory, Research, Practice, Training, 28, 444-447. Lilienfeld, S. O. 2010, Can Psychology Become a Science? Personality and Individual Differences, 49, 281-288. Lilienfeld, S. O., Lynn, S., J. and Law, J. M. 2003, Science and Pseudoscience in Clinical Psychology. New York, Guilford. L. NFELD, S. O. and ODONOHUE, W. T. 2012. Great Readings in Clinical Science, Essential Selections for Mental Health Professionals. Boston, Massachusetts, Pearson. McFall, R. M. 1991, Manifesto for a Science of Clinical Psychology. The Clinical Psychologist, 44, 6, 75-88. Nezu, A. M., Nezu, C. M., Maguth, C. and Lombardo, E. 2004, Cognitive Behavioral Case Formulation and Treatment Design, A Problem-Solving Approach. New York, Springer. O'Donoghue, W. and Benuto, L. 2011, Problems with the Construct of Cultural Sensitivity. Scientific C Review of Mental Health Practice, 7. 24-37. O'Donoghue, W. and Fisher, J. E. 2009, The Role of Quality Improvement. In J. Fisher and W. O'Donoghue, eds. The Practitioner's Guide to Evidence-Based Treatment, pp. 1-32. New York, Springer. O'Donoghue, W. and Henderson, D. 1999, Epistemic and Ethical Duties in Clinical Decision-Making. Behavior Change, 16, 10-19. XFI. Introduction. O'Donoghue, W. 1991, Normative Models of Treatment Decisions. The Behavior Therapist, March 14, 70-72. O'Donoghue, W. and Heaton, J. in Preparation. What is a Psychological Intervention Error? P. RSONS, J. 2008. The Case Formulation Approach to Cognitive Behavior Therapy. New York, Guilford Press. P. I. PPER, K. R. 1965. Conjectures and Refutations, The Growth of Scientific Knowledge. New York, Harper. Ruscio, J. 2007, The Clinician as Subject, Practitioners are subject to the same judgment errors as everyone else. In S. O. Lilienfeld and W. O'Donoghue, eds, The Great Ideas of Clinical Science, 17 Principles that Every Mental Health Professional Should Understand, pp 29-48. New York, Taylor and Francis. Ullman, L. P. 1977, Behavioral Community Psychology, Implications, Opportunit. SANDRESPONSIBILITIES. INM. T. NIETZELR. A. WINETT. L. MACDONALD, and W. S. DAVIDSONEDS. Behavioral Approaches to Community Psychology. pp. IXXXVII. New York, Pergamon Press. ARTIO. This page intentionally left blank. 10. AMANDAM. NZIANDSHEILAM. EYBERG. It is a myth that treatments following a manual look the same for all cases. This case study illustrates how an empirically supported treatment may be substantially tailored to the needs of the family while maintaining treatment fidelity. Alvin is a 4-year-old African-American boy who was initially referred by his caseworker for assessment of possible intellectual delay and for treatment of his behavior problems. The caseworker had sent case notes detailing a history of severe neglect. Until he was removed from his biological mother's home, Alvin had been confined in a high chair during most of every day. He had also witnessed frequent physical abuse of his 3-year-old sister, although he had not himself been physically abused. The case notes indicated that when Alvin was placed with his grandmother, she had been concerned because he spoke very little and played alone for extended periods of time, avoiding interactions with both his grandmother and his sister. Key principles or core knowledge. In our initial approach to this case, we drew on the literature describing the characteristics of children with histories of maltreatment. These children are at higher risk than children in community samples for developing internalizing and externalizing psychological disorders, social skills deficits, school problems, aggressive behavior, post-traumatic stress disorder, and adaptive functioning delays. Clausen, Landsberg, Chadwick, and Litronic, 1998, Marcus, 1991. Children under the age of 6 in the welfare system are particularly vulnerable to negative outcomes associated with multiple placements, including developmental delay. Fisher, Buraston, and Pears, 2005, and attachment disruptions. Bayer and Martinez, 2006, if maltreatment occurs on multiple occasions. 4 childhood disorders. ASSESSMENTSTRATEGY. Based on information from the case notes, we identify at the assessment domains to include clinical interview, standardized testing, and structured behavioral observations. We plan to use the clinical interview to elaborate and clarify the presenting concerns. To address the PHI-IST referral question concerning Alvin's intellectual functioning, we plan to administer the Wechsler Preschooler and Primary Scale of Intelligence 3, WPPSI-3, Wechsler, 2002. To explore Alvin's behavior problems and his relationship with his grandmother, we plan to use the dyadic parent-child interaction coding system for DPICSIV, Aberg, Nelson, Jin, Bayan, and Boggs, in Press, which provides a functional analysis of Alvin's behaviors and the conditions that maintain them. We plan to select standardized caregiver report instruments based on interview and observation data to help CONFI-RM initial diagnostic hypotheses. Our initial assessment strat. EG was based on well-researched, multi-method diagnostic procedures. At the time we met Alvin and his grandmother, Alvin had been in her home for 3 months. In the waiting room, Alvin was playing with toys on the FL or by himself. He initially ignored requests from his grandmother to come with us to the examination room. His grandmother walked over to him and explained sweetly, "It's time to go with the ladies now, Alvin. Please don't make me have to feel bad." After a minute, she attempted to pick him up, and he began screaming and resisting her efforts as she physically led him to the playroom. Once in the playroom, Alvin began excitedly playing with the toys. Because of the sensitive nature of the interview information, we asked his grandmother if she would be comfortable with Alvin playing in this room while we talked in the adjoining observation room, so that we could keep an eye on him and talk freely. During the clinical interview with Alvin's grandmother, she confirmed the information from the case notes detailing Alvin's significant history of neglect and his symptoms of oppositional defi and disorder of being non-compliant, easily annoyed, and quick to anger, and having frequent temper tantrums. She described some continuing concern about his unresponsiveness to her, and in particular his refusal to let her hug him or show affection, as well as extreme irritation and bossiness toward his sister whenever she tried to join in his play or touch his things. Alvin's grandmother also elaborated on Alvin's refusal to do what she asked, which involved severe temper tantrums in response to her direction, often lasting for as long as an hour or until she withdrew her demand. However, she proudly reported that since coming to live with her, Alvin had learned to use utensils appropriately when eating and had gone from barely speaking when he FIRST arrived to having become a chatterbox. Our initial assessment plan was to evaluate Alvin's intellectual functioning to rule out intellectual disability. He willingly followed the therapist to the testing room, but he refused to sit at the table. Despite the many different strategies that were employed to engage him in formal testing, Alvin's oppositional behavior escalated. He tested many limits by repeatedly crawling under and jumping up from under the table, and then he progressed to more aggressive behaviors. Tailoring parent-child interaction therapy. 5. Throwing papers off the table and attempting to rip pages from the test booklet. We thought it might be necessary to treat Alvin's behavior problems before adequate intellectual testing could be accomplished. We continued with the assessment, administering standardized questionnaire measures to evaluate both a. Alvin's broadband psychological functioning, using the Behavior Assessment System for Children, version 2 BASC 2, Reynolds and Camfors, 2004, and b. His grandmother's parenting stress, using the Parenting Stress Index, short form PSISF, Aberdeen, 1995. Results from the BASC-2 indicated clinically significant externalizing behavior problems, with highest scores on subscales of aggression and conduct problems, and subclinical elevations on activities of daily living, including the subscales of adaptability and social skills. Internalizing behavior problems were rated in the average range. On the PSISF, Alvin's grandmother's scores were at the 35th percentile on the parent distress subscale, at the 70th percentile on the parent-child dysfunctional interaction subscale, and at the 85th percentile on the difficult child subscale. The Informer tie-on from these instruments provided initial hypotheses for our diagnostic formulation, including Alvin's primary presentation of anger and defiance as well as his diminished interpersonal and adaptive functioning. The testing information also reflected the grandmother's distress over Alvin's behaviors and the quality of their relationship. While Alvin's grandmother completed these questionnaires, the therapist played with Alvin and collected informal observations of his behavior. When invited to play with cars, Alvin was immediately excited and eagerly pulled them out of the toy box. The therapist joined him by the cars and described his play. Although Alvin didn't make eye contact with the examiner, he created stories about the cars and continued his stories enthusiastically in response to the therapist's comments. The therapist told Alvin that she had to step out for a minute to check on his grandmother. He then made eye contact and asked, "Are you leaving me?" Despite reassurance, Alvin stood and approached the therapist and continued to repeat statements such as, "When are you coming back?" and "Are you coming back?" Alvin's grandmother had finished her questionnaires and returned with the therapist to the playroom. When they entered, Alvin ran up to the therapist and hugged her legs, and then described his car game to her in an animated manner, without acknowledging the presence of his grandmother. After a break, we introduced the 3 DPICSIV standard situations that we would use to observe the interactions between Alvin and his grandmother. For the FIRST 5-minute observation, we asked the grandmother to let Alvin lead the play in the low-demand, child-led play situation. Alvin sat at the opposite end of the play table from his grandmother and again played enthusiastically with the cars. His grandmother asked him many questions about his play, but Alvin did not respond to her inquiries. When his grandmother asked if she could play with the cars, too, Alvin responded, "No, they are for the other lady." In the second DPICSIV situation, called parent-led play, we asked the grandmother to choose the play activity. She asked Alvin if he would like to draw with the crayons, and he said, "I need to put the cars through the car wash FIRST. The 6 childhood disorders." Grandmother responded, "Okay, that's good. Then can we draw?" And Alvin said, "The cars have to get dry. You draw it." He responded to most of her commands with counter-commands during this 5-minute observation. In the final, high-demand situation, clean up, Alvin's grandmother was asked to have Alvin put the toys away by himself. After asking him once if he would like to clean up the toys, his grandmother began putting the toys away and asked him if he thought it would be fun to see who could clean up the fastest. She continued to suggest ideas that might get Alvin to help, but when she became more insistent, Alvin started screaming and throwing the toys at the toy box across the room. The DPICSIV data indicated that the grandmother's primary verbalizations in all 3 situations were questions, including indirect commands, e.g., would you like to? Acknowledgements, e.g., okay, and unlabeled praises, e.g., good. Each of these brief verbalizations was repeated very frequently, stated warmly, and suggested highly permissive parenting. Her praise and positive attention occurred both when she approved and when she disapproved of Alvin's behavior. He did not comply with any of his grandmother's indirect commands. Epidemiological and contextual considerations for case formulation. The results of the psychological evaluation showed consistent evidence of oppositional and defiant behaviors across interview, BASC-2, and behavioral observations of Alvin's response to high-demand situations, suggesting a diagnosis of oppositional defiant disorder, ODD. ODD is a highly prevalent mental health diagnosis among young children and one of the most common reasons for referral to child mental health clinics, Luber, Burke, Leahy, Winters, and Zira, 2000. On the PSISF, his grandmother's results were within the normal range except on the difficult child scale, suggesting that her distress was limited to concerns about his behavior. In our observations of Alvin's responses to the therapist and his grandmother, it was evident that Alvin also engaged in excessive familiarity with relative strangers and was often unforthcoming with his grandmother. His history of severe neglect and his developmentally inappropriate social interactions suggested difference occultize beyond those expected in ODD and were consistent with a diagnosis of reactive attachment disorder of early childhood, RAD, American Psychiatric Association, DSM-IVTR, 2000. To diagnose RAD, it is necessary to rule out intellectual delay and pervasive developmental disorder. Because Alvin demonstrated with the therapist the ability to engage in appropriate social conversation and to initiate eye contact, combined with his history of normal speech and motor development and the absence of stereotyped behaviors, we were able to rule out a diagnosis of pervasive developmental disorder. Despite our inability to complete intellectual testing, we felt comfortable ruling out intellectual disability at this time, based on the BASC-2 results of Alvin's adaptive behaviors and our observations of his current developmental skills. There are neither psychometrically sound studies examining tailoring parent-child interaction therapy. 7. The diagnostic accuracy of an attachment disorder among maltreated children, nor any evidence-based assessment instruments for this diagnosis, Chaffee et al., 2006. In addition, there is little systematically gathered epidemiological information on the prevalence, incidence, or natural course of RAD that could be used to confirm our diagnosis, Chaffee et al., 2006, Hansen and Spratt, 2000. Case formulation. At the conclusion of the evaluation, we provided brief feedback to Alvin's grandmother. We FIRST commented that it was good she came in to seek help for Alvin's behavior, and that the assessment results indicated that his oppositional and defiant behavior was more frequent than that seen in most children of his age. We then discussed the contrasting responses that Alvin showed to his grandmother and the therapist, and explained that within the context of his history of maltreatment, Alvin had perhaps learned that caregivers could be more unpredictable and inconsistent in meeting his needs than unfamiliar adults, which might lead him to be less comfortable with caregivers and more willing to trust unfamiliar adults with whom he has not experienced such an unpredictable history, Howe and Fernley, 2003. Selecting an intervention model. The challenge of selecting an evidence-based intervention for Alvin and his grandmother was to select an intervention that would address his diagnosis of ODD while maintaining sensitivity to his difficult attachment behaviors. There are at least 5 evidence-based parent training interventions for disruptive behavior in preschool-age children, Aberg, Nelson, and Boggs, 2008. Among these treatments, parent-child interaction therapy, PCIT, is an intervention also identified as a best practice for helping children recover from the impact of abusive experiences, Chadwick Center on Children and Families, 2004, and for this reason it was considered for Alvin's treatment. Although there is no intervention that has been identified as empirically supported for treating RAD, PCIT meets the American Professional Society on the Abuse of Children, APSAC, Task Force Guidelines for Treating Children with Attachment Problems, Chaffee et al., 2006. These guidelines indicate that the treatment for attachment problems should be based in both behavioral and attachment theories, and should be evidence-based for the primary presenting problem of the child. The APSAC guidelines further indicate that the interventions should be short-term, should involve the primary caregiver, and should focus on increasing parental sensitivity. For these reasons, we selected PCIT as the treatment we would use in this case, Aberg and Funderburg, 2011. PCIT outcome studies evidence increases in positive parenting skills and decreases in disruptive child behavior, Zisser and Aberg, 2010, and physical reabuse rates, Chaffee et al., 2004, Thomas and Zimmerjembeck, 2011, 2012. The conceptual foundation of PCIT is based broadly in the developmental and behavioral 8 childhood disorders. Literature. PCIT is based on Baumrinn's 1966-1991 developmental theory, which holds that authoritative parenting, a combination of nurturance, good communication, and behavioral regulation, produces optimal child mental health outcomes. By providing caregivers with the skills to attend selectively to child behavior, the caregiver also learns to be more sensitive to the child, to respond with greater warmth, and to become more emotionally available, thus creating a more secure caregiver-child attachment and reducing parent stress. Eisenstadt, Aberg, McNeil, Newcomb, and Funderburg, 1993, Fussell, NZ, and Aberg, 2012. In PCIT, parents learn authoritative parenting skills during 2 sequential phases of treatment. In the PHI-RST phase, parents learn to follow their child's lead in play by providing attention to positive child behavior, combined with active ignoring of negative child behavior, to create an empathic, nurturing parent-child interaction called the child-directed interaction, the CDI. During the second phase of PCIT, called the parent-directed interaction, PDI, parents learn to direct their child's behavior when necessary and to provide consistent consequences. PCIT is a performance-based intervention in which the caregiver's skills and the child's behaviors are monitored weekly to guide progress through treatment and to determine when treatment ends. The caregiver's report of the child's behavior, using the Aberg Child Behavior Inventory, ECBI, Aberg and Pincus, 1999, and behavioral observation of the caregiver's treatment skills, using the DPICSIV, are assessed at the beginning of each session. The results of these measures are graphed weekly and are reviewed with the caregivers at the end of each session. Alvin's treatment. At the feedback session, we established the plan for Alvin's treatment. Because Alvin was in a temporary guardianship arrangement with his grandmother, it was important to explore the stability of this placement. If there were a possibility of reunify Cation with his biological mother, it would be important to involve her in treatment to establish the primary attachment relationship with the anticipated permanent caregiver. The grandmother informed us that Alvin's long-term placement plan was adoption by his grandmother due to the unstable psychological condition of his biological mother. As a result, the decision was made to proceed with PCIT, including only Alvin and his grandmother. His grandmother expressed initial hesitancy about treatment with us because of difficulties with transportation to our center and her own discomfort with navigating the unfamiliar environment of the large health science center. We arranged to see Alvin in a satellite clinic at their community center for treatment. The following week, Alvin's grandmother attended the PHI-RST PCIT session, the CDI teaching session, alone. In this session, caregivers learn to follow the child's lead in play with positive attention, expressing approval and enjoyment of the child's ideas, behaviors, and activities by describing and praising the child's positive play behaviors and by reflecting or paraphrasing the child's comments during play. At the same time, caregivers learn to avoid intrusive verbal behaviors such tailoring parent-child interaction therapy. 9. As questions, commands, and criticism, which can give attention to and increase negative child behaviors. Through the behavioral mechanisms of modeling and differential social attention, many negative child behaviors drop away during the CDI, and the parent-child play begins an upward cycle of mutually reinforcing and responsive interactions. In the CDI teaching session, the therapist demonstrates the individual skills of the CDI, role-plays the skills with the parents, and describes the emotional and behavioral effects of each skill on the child. Near the end of the session, when reviewing the kinds of toys that work best when practicing the skills at home, the grandmother mentioned that Alvin did not have many toys besides his tricycle and football. The therapist described some ways to make toys out of household items, such as how to use pots and pans in play and how to create a giant block set out of old cereal and oatmeal boxes. All subsequent sessions in the CDI phase of treatment are called CDI coaching sessions. In these sessions, the caregiver and child practice the CDI skills together in the playroom while the therapist observes and coaches the caregiver from an observation room. The coaching sessions begin with a 5 to 10 minute check-in when the therapist and caregivers review the CDI homework and the child's behavior during the previous week. The therapist then has the caregiver begin practicing the CDI with the child while the therapist codes the interaction from an observation room. By coding or tallying the frequency of the caregiver's skills during a 5-minute observation, the therapist can assess the progress made since the previous session and can determine which skills to focus on during coaching. When coaching the CDI, the therapist initially focuses on following the caregiver's lead, commenting positively on the parent's use of the new skills, just as the caregiver follows the child's lead in the CDI. One of the most effective kinds of coaching statements is a short, labeled praise, such as nice description, or excellent behavior to praise, after the caregiver uses a CDI skill. Coaching in CDI becomes slightly more directive after 1 or 2 coaching sessions, when caregivers are comfortable with the procedure. For example, a therapist might suggest that the caregiver praise a particular behavior, e.g., you could praise him for sharing with you, to help caregivers notice cooperative behaviors. At the FI-RST CDI coaching session, we reviewed the PCIT homework sheet, Aberg and Funderburg, 2011, see Figure 1.1, which showed that Alvin's grandmother had practiced all 7 days since the teaching session. To reinforce the importance of daily homework practice, the therapist took time to discuss all of the comments that Alvin's grandmother had written and to praise the good toy and activity choices she had come up with, which included building towers with food cans from the pantry. During observation of the CDI interaction, the grandmother increased her use of labeled praises from 0 at the pre-treatment assessment to 5 VE, and decreased her questions from 53 to 20, although she continued her indiscriminate use of unlabeled praise. Alvin directed more of his play talk to his grandmother during this observation than at the pre-treatment assessment. He remained distant from his grandmother, though, by moving toy animals across the room to play there with them. When coaching in this session, it can be tempting to give corrective feedback, but we maintained the focus on the grandmother's positive use of the skills while ignoring mistakes. Our 10 childhood disorders goals in this session were to increase the frequency of her CDI skills and to model the interaction skills that she was learning to use with her child. When reviewing the observation data with Alvin's grandmother at the end of the session, rather than commenting that she still asked many questions during the play, we emphasized her improvement in decreasing questions, as well as our observation that Alvin spoke to her somewhat more this week. She mentioned that Alvin had started talking to her more at home also. The therapist pointed out the connection between this change and the grandmother's consistent homework practice, and commented that her practice seemed to be reflected on her ECBI graph as well. When discussing homework for the next week, Alvin's grandmother decided to focus on increasing her reflections of Alvin's speech, because he seemed to enjoy it during coaching. Alvin's grandmother continued to practice homework daily, and at the second CDI coaching session, she described continued improvements in his behavior at home, including fewer temper tantrums during the week. During the 5-minute CDI homework sheet, mother ____ father ____ child's first name ____ did you spend 5 minutes in special time today? Date yes, no activity problems or questions in special time Monday ____ Tuesday Wednesday Thursday Sunday Figure 1.1 CDI homework sheet. Tailoring parent-child interaction therapy. 11. Coding. She demonstrated improvement in the frequency of her reflections, but her questions remained high and she often did not seem aware of asking a question. Alvin continued to increase the frequency of comments he directed to his grandmother about the play. His grandmother joined Alvin to play on the FL-OR, and he did not move away. However, she shifted uncomfortably while sitting on the FL-OR, and it seemed that her discomfort was affecting her ability to focus on the treatment skills. Before coaching began, the therapist entered the playroom to praise the grandmother for following Alvin's lead by moving to the FL-OR to play next to him and asked if she would be more comfortable if some of the toys were moved to the table. The grandmother agreed, and Alvin helped her move the toys. The therapist prompted his grandmother to praise him for playing with her at the table. While in the room, the therapist told the grandmother that reducing questions would be a focus of today's coaching. She asked if the grandmother would find it helpful or annoying if the therapist signaled her over the bug each time she heard the grandmother ask a question, to help the grandmother become more aware of them. The grandmother expressed enthusiasm, and the plan was made for the therapist to signal by saying question, after which the grandmother would attempt to restate the question as a statement. During subsequent coaching, the grandmother increasingly caught her own questions midstream or before. When Alvin and his grandmother came to the third CDI coaching session, his grandmother was beaming. She reported that Alvin had gotten ready for bed without a temper tantrum for the last 3 days, and Alvin said to the therapist, "I went to bed fast," with a big smile on his face. The therapist asked the grandmother what she thought had contributed to this change, and the grandmother mentioned that she had been praising Alvin for getting ready quickly each time he did it. The therapist pointed out that the grandmother had used a positive opposite praise, i.e., going to bed quickly, instead of focusing on the problem behavior, i.e., getting ready slowly, and that she had used one of the best kinds of praise to help Alvin change his behavior. During the DPICSIV observation of their interaction, Alvin's grandmother was catching most of her questions, restating them as CDI skills, and she had also increased her labeled praises to 5. Still, she continued to use the unlabeled praise, good, indiscriminately in response to many of Alvin's comments, including comments he made that were bossy or that contradicted something she had done, such as telling her to put a toy in a different place than she had. Even though Alvin continued to tell his grandmother what to do, he sat closer to her, and his directions were stated more matter-of-factly than with anger. The therapist gave the grandmother feedback about her use of the word good, and said that today she was going to focus coaching on labeling her praises for behaviors that she wanted to see again, like sharing. The therapist also coached the grandmother to ignore Alvin's bossy statements, often by praising her for staying quiet, good ignoring, before she had the chance to say good. After coaching for only a few minutes, Alvin's grandmother dramatically increased her labeled praise of Alvin's positive opposite behaviors, and Alvin became increasingly engaged with his grandmother in play. Notably, he was asking nicely more often for his grandmother to join his play in a particular way, rather than telling her what to do. 12. Childhood disorders. Alvin and his grandmother arrived 10 minutes late to the fourth CDI coaching session, and his grandmother appeared distraught. During the check-in, she described losing her social security check, and began to elaborate on the consequences of losing this check. The therapist responded empathically to her concerns and then told her that at the end of the session, she would connect her with the social worker at the community center who arranges emergency funding services. This interaction illustrates another common trap that the therapist avoided. Instead of using the session time to process the distressing event, or attempting to help the grandmother problem solve a solution, the therapist found a way to refocus the grandmother on the session goals and avoid derailing the child's progress. The grandmother's CDI skills had continued to improve during the previous week and during in-session coaching. Her improved mood at the end of the session may have helped her work more effectively with the social worker, who was able to obtain emergency funding. In the FI FTH CDI coaching session, the grandmother brought in a blank homework sheet and stated that she had practiced special time only twice in the past week, because she was just using the skills all day long. During coding and coaching, the therapist observed that Alvin's grandmother had to ignore negative and bossy statements more often than in recent sessions. When she scored the ECBI, she also noted that Alvin's behavior problems had increased, and although they were still below the clinical range, they were noticeably higher than they had been the week before. This pattern on the ECBI graph often reflects a decrease in homework practice. During the review of the ECBI graph, the therapist described this pattern to the grandmother and used motivational enhancement strategies to facilitate the grandmother's commitment to resuming special time practice sessions each day. Alvin's grandmother said that Alvin had asked to have special time a few times, and she reflected on his requests as both a positive sign and an indication that their one-on-one time was important for preventing their progress from backsliding. At the 6th CDI coaching session, Alvin's grandmother's skills had greatly improved from previous weeks, and she had almost achieved the CDI mastery criteria. She ignored his 3 bossy statements effectively, and Alvin did not give his grandmother any direction for how to play during the second half of the session. The warmth of the interaction was qualitatively improved as well. They laughed together in session, and Alvin rested his head on his grandmother's shoulder when she told him she was proud of how polite he was being. Alvin did not pull away when she put her arm around him. The grandmother's ECBI score had reached the criterion level for treatment termination, and she expressed more confidence in her ability to manage his behavior by using the skills throughout the day, as well as during their special time. The therapist pointed out that she was very close to mastery of the CDI skills, and that her description of Alvin's behavior on the ECBI placed his behavior well into the normal range at this point in treatment already. The therapist discussed the importance of thinking about her and Alvin's progress towards meeting their treatment goals in order to reevaluate their treatment plan during the next session. As the therapist had anticipated, during the 7th CDI coaching session, Alvin's grandmother met mastery criteria for the CDI skills. Her ECBI ratings of tailoring parent-child interaction therapy 13. Alvin's behavior at home continued to be within the average range for children his age, and she continued to report confidence in managing his few remaining behavior problems. Because she was able to manage his behavior adequately with positive attention and active ignoring, moving on to the PDI phase of treatment was not obligatory. The therapist considered potential advantages and disadvantages of this second phase for Alvin and his grandmother, in which caregivers learn to set fair but firm limits and to follow through on their rules with a timeout consequence for non-compliance, in addition to praise for compliance. For children with ODD who have not experienced consistent limit setting and follow-through, the timeout procedure is usually emotionally distressing initially. With the recent, still developing attachment relationship between Alvin and his grandmother, the therapist decided to recommend not moving into the PDI phase of PCIT. The therapist discussed these issues with Alvin's grandmother, who agreed, and added that she felt that she and Alvin had met their treatment goals and were ready to graduate. The therapist discussed the importance of continuing daily special time and scheduled a follow-up call with the grandmother in 1 month to check on their continued progress. The therapist also let the grandmother know that she could contact her before their scheduled follow-up call if she had any concerns about Alvin's behavior. Review of general therapy process. Many non-specified C issues common across all treatments were exemplified in the case of Alvin and his grandmother, Aberg, in press. Dealing with adherence issues was evidenced by the therapist's response to homework non-compliance in the FI FTH CDI coaching session. The therapist pointed out the correspondence between practice and progress that can be seen weekly on the ECBI graph, enhancing the grandmother's motivation to complete homework consistently. See Figure 1.2. This case also illustrated ways in which the therapist was able to avoid common mistakes that can harm the therapeutic alliance or therapy progress. For example, when the grandmother arrived at the 4th CDI coaching session in distress regarding her finances, the therapist validated her concerns, but maintained focus on the established treatment goals. Consideration of cultural factors in this case were highlighted by the therapist's sensitivity to the caregiver's socio-economic situation, as shown by holding sessions at an easily accessible facility in the grandmother's community to reduce financial burden. Ethical considerations were demonstrated when the therapist explored the long-term custody arrangements with the grandmother to ensure that treatment intervention established an attachment relationship with the caregiver most likely to be permanent. Highly important process issues arise when addressing treatment termination and relapse prevention. In this case, the therapist critically evaluated with the grandmother the need for further treatment once the identified treatment goals were achieved. A concrete plan was established for maintaining gains, and a follow-up call was scheduled to monitor progress and prevent relapse. 14. Childhood disorders. ECBI graph. 80. 75. 70. ECBIT score. 65. 60. 55. 50. 45. 40. CDI Teach. CDI 1, CDI 2, CDI 3, CDI 4, CDI 5, CDI 6, CDI 7. Session. Figure 1.2. Graph of the grandmother's weekly ratings of Alvin's behavior problems during treatment on the ABERG Child Behavior Inventory, ECBI. This case illustrates how the use of PCIT for a child with ODD and RAD can maintain fidelity to the treatment protocol while addressing the unique presentation of the individual family. In all evidence-based treatments, the pre-treatment assessment is essential to the process of tailoring treatment effectively. A diagnosis of ODD often occurs with comorbid disorders, and complex contextual factors are present in many families of children with ODD. Nock, Kasdan, Herpy, and Kessler, 2007. A comprehensive multi-method assessment provided information on 3 important aspects of this case that guided our treatment selection and planning. The child's history of maltreatment and his diagnosis of ODD led us to select PCIT as an appropriate evidence-based treatment. In considering the relatively uncommon diagnosis of RAD, we sought guidance from the literature. The recommendation that treatment be grounded in both behavioral and attach ment theories also suggested that PCIT would be an appropriate FIT. Observational data provided key information on the child's attachment behaviors and the grandmother's permissive parenting style for the considerations in tailoring coaching during treatment. These observations were supported by the additional standardized questionnaires completed by the primary caregiver. One strategy used in coaching with this case was to increase the grandmother's positive verbal attention to the child's initially limited conversation. A second coaching strategy was to increase the selectivity and specificity of the grandmother's praise to the child, which more effectively conveyed her approval while enhancing the child's trust in her as a safe and nurturing caregiver. As mutual security in the relationship increased, the child became less insistent on remaining in control of their interactions and gradually began accepting the grandmother's. Tailoring parent-child interaction therapy. 15. Suggestions for play. The grandmother became more open to coaching recommendations to ignore inappropriate behavior, and as a result, she was able to use differential social attention effectively to manage her grandson's behavior, setting in motion a positive reinforcement cycle. Treatment was completed when the grandmother's CDI skills reached mastery level, enabling her to manage and maintain the child's behavior within normal limits for disruptive behavior. The decision to end treatment at this point was in consideration of the potential for mutually reinforcing positive interactions to continue improving child behavior problems. Hood and ABERG, 2003, and for the child's newly formed attachment to his caregiver to be protected from unnecessary emotional distress when so little is known about treating children meeting diagnostic criteria for RAD. REFERENCES. ABIDIN. R. 1995. Parenting Stress Manual, 3rd ed. Odessa, Florida, Psychological Assessment Resources, Inc. American Psychiatric Association. 2000, Diagnostic and Statistical Manual of Mental Disorders, 4th ed, Text Revision. Washington, D.C., author. B. E.R., J. C. and MARTINEZ, C. D. 2006. CHILDMALTREATMENTA and DINSECUREATTACHMENT, a meta-analysis. Journal of Reproductive and Infant Psychology, 24, 187-197. doi, 10.1080, 0264683060082123 Baumrind, D. 1966. Effects of Authoritative Parental Control on Child Behavior, Child Development, 37, 887-907. doi, 10.1111, J.1467-8624.1966.TB05416.XB. I. UMRIND, D. 1991. THEINFLUENCE of Parenting Style on Adolescent Competence and Substance Use. Journal of Early Adolescence, 11, 56-95. doi, 10.1177, 0272431691111004. Chadwick Center on Children and Families. 2004, Closing the Quality Chasm in Child Abuse Treatment, Identifying and Disseminating Best Practices. San Diego, California, author. CHAFIN, M. Silovsky, J. F. Funderburk, B. Vale, L. A. Breston, E. V. Balachova, T. Borna, B. L. 2004. Parent-Child Interaction Therapy with Physically Abusive Parents, Efficacy for Reducing Future Abuse Reports. Journal of Consulting and Clinical Psychology, 72, 500-510. doi, 10.1037, 0022-006x.72.3.500 CHAFIN, M. HANSON, R. SAUNDERS, B. E. NICHOLS, T. BARNETT, D. ETAL. 2006. REPORT of the APSAC Task Force on Attachment Therapy, Reactive Attachment Disorder and Attachment Problems. Child Maltreatment, 11, 76-89. doi, 0.1177, 10775595052836999. CLAUSEN, J. M. LANDSVERK, J. GANGER, W. CHADWICK, D. and LITROWNIK, A. 1998. M. Entor. Health Problems of Children in Foster Care. Journal of Child and Family Studies, 7, 283-296. E. ENSTADT, T. EYBERG, S. MCNEIL, C. NEWCOMB, ANDFUNDERBURK, B. 1993. PAR Child Interaction Therapy with Behavior Problem Children, Relative Effectiveness of 2 Stages, and Overall Treatment Outcome. Journal of Clinical Child Psychology, 22, 42-51. doi, 10.1207, S153744424 JCCP, 2201_4. Aberg, S. M. in Press. Principles of Treatment with the Behaviorally Disordered Child. In G. P. Coucher, J. C. Norcross, and B. A. Green, Psychologists Desk Reference, 3rd ed. New York, Oxford University Press. 16. Childhood Disorders. Aberg, S. M. and Funderburk, B. W., 2011. Parent-Child Interaction Therapy Protocol. Gainesville, PCIT International. EYBERG, S. M. NELSON, M. M. and BOGGS, S. R. 2008. EVIDENCE, BASEDT, REATMENTS, FOR Child and Adolescent Disruptive Behavior Disorders. Journal of Clinical Child and Adolescent Psychology, 37, 213-235. doi, 10.10 2 F15374410701820117. Aberg, S. M. Nelson, M. Jin, N. C. Buyani, N. and Boggs, S.R. in Press. Manual for the Dyadic Parent-Child Interaction Coding System, 4th ed. Gainesville, Florida, PCIT International. EYBERG, S. M. and PINCUS, D. B. 1999. Aberg Child Behavior Inventory and Sutter Aberg Student Behavior Inventory, Professional Manual. Odessa, Florida, Psychological Assessment Resources. FISHER. P. BURRASTON, B. and PEARS, K. 2005. THEEARLYINTERVENTIONFOSTER Care Program, Permanent Placement Outcomes from a Randomized Trial. Child Maltreatment, 10, 61-71. doi, 10.1177, 1077559504271561561 FUS, SELL, R. NZIA. M. and EYBERG, S. M. 2012. Emotional Abuse and Attachment, a Parent-Child Interaction Therapy Study. Manuscript in preparation. Hansen, R. F. and Spratt, E. G. 2000. Reactive Attachment Disorder, What We Know About the Disorder and Implications for Treatment. Child Maltreatment, 5, 137145. doi, 10.1177, 1077559500005002005. Hood, K. K. and Aberg, S. M. 2003. Outcomes of Parent-Child Interaction Therapy, Mother's Reports on Maintenance 3 to 6 years after treatment. Journal of Clinical Child and Adolescent Psychology, 32, 419429. Howe, D. and Fernley, S. 2003. Disorders of Attachment in Adopted and Fostered Children, Recognition and Treatment. Clinical Child Psychology and Psychiatry. 8, 369-386. doi, 10.1177, 135-91045-030080030007 KNOCK, M. A. KAZDIN, A. E. HIRPIE. and KESSLER, R. C. 2007. LIFETIME EPREVALENCE, CO related, and persistence, of oppositional deafy and disorder, result from the National Comorbidity Survey replication. Journal of Child Psychology and Psychiatry, 48, 703-713. doi, 10.1111, J.1469, 76, 10.2007.01733.XL. I. EBERR. BURKE, J. D. LAHEY, B. B. WINTERS, A. and ZERA, M. 2000. OPPOSITIONAL Deafy and Disorder, A Review of the Past 10 Years, Part 1. Journal of the American Academy of Child and Adolescent Psychiatry, 39, 1468-1484. doi, 10.1097% 2F0004583-2000120000-00007 M. ARCUS, R. F. 1991. THEATTACHMENTSOFCHILD Genetic, Social and General Psychology Monographs, 117, 365-394. REYNOLDS, C. R. and KAMPHAUS, R. W. 2004. Behavior Assessment System for Children, 2nd ed. Basque 2. Circle Pines, Minnesota, AGS Publishing. Thomas R. and Zimmergenbeck, M. J. 2012. Parent-Child Interaction Therapy, an Evidence-Based Treatment for Child Maltreatment. Child Maltreatment, 17, 253-266. doi, 10.1177, 10775595124595555. Thomas R. and Zimmerjembeck, M. J. 2011. Accumulating Evidence for Parent-Child Interaction Therapy in the Prevention of Child Maltreatment. Child Development, 82, 177-192. doi, 10.1111, j.1467, 8624.2010.01548.xwechsler, d. 2002. Wexler Preschool and Primary Scale of Intelligence, 3rd ed. WPPSI 3. San Antonio, Texas, Psychological Corporation. Z. SERA. And EYBERGS. M. 2010. TREATIONALBEHAVIORINCHILD Rent-Child Interaction Therapy. In A. E. Kasdan and J. R. Weiss, eds. Evidence-Based Psychotherapies for Children and Adolescents, 2nd ed. pp. 179-193. New York, Guilford. C. Mentory. TRICKC. FRIMANANDSTACYSHAW. There is much to admire in this report of an adaptation of parent-child interaction therapy, PCIT, used to treat a uniquely complex case involving comorbid reactive attachment and oppositional deficit disorders. On the one hand, the paper reflects the remarkable potency and flexibility of PCIT. On the other hand, it reflects the clinical acumen and interpersonal dexterity of the clinicians who reported the case. We will discuss both of these aspects below. We both came into contact with PCIT-related material during graduate school, although at dramatically different points in time. My Fryman initial contact was during my Phi-RST year in graduate school, 1980, when I was assigned a highly relevant reading, Ped. Roberts, and Forehand, 1977. Stacey Shaw's initial contact also occurred during her Phi-RST year of graduate school, 2005, when she was assigned the same reading for a clinical practicum led by one of its authors, Mark Roberts. As a review of the relevant literature shows, Mark Roberts contributed significantly to the early empirically derived knowledge base that has contributed to PCIT, e.g., Roberts, Hatzenbuehler, and Bean, 1981, Roberts, McMahon, Forehand, and Humphreys, 1978, and PCIT is, arguably, the most widely used and empirically supported approach to disruptive behavior in young children in the history of child psychology. But there are two other sources that are worth mentioning here. Both are remarkable, but for different reasons. The Phi-RST is a now legendary woman whom we did not have the opportunity to meet, Constance Hanff. She was a professor at the Oregon Health Sciences University, OHSU, where she had a tremendous impact on child clinical psychology. Specify Cowley, she formulated the Phi-RST two-stage parent training protocol, which remains the basis for many of the behavioral parent training protocols in existence today, including PCIT. Hanff's influence is rather remarkable given that her work was never published. Her name appears on only one conference presentation and two unpublished manuscripts, Hanff, 1969, Hanff, 1970, Hanff and Kling, 1973. Instead, her influence appears to be primarily derived through the interns and postdoctoral fellows whom she trained at the OHSU. Dr. Hanff's students read like a who's who of child clinical psychology, e.g., Rex Forehand, Sheila Aberg, Russell Barkley, and it is they and their students, e.g., Cheryl McNeil. Carolyn Webster Stratton, who went on to refi NE, test, and ultimately disseminate her approach. 18. Childhood disorders. The second name that deserves special attention here is the second author of the source document for these remarks, Sheila Aberg. As noted above, Dr. Aberg is one of several prominent psychologists who trained at the OHSU with Dr. Hanff. Dr. Aberg herself went on to produce one of the more rigorous, generative, and creative lines of systematic replication in the Phi-ELD of applied child psychology, e.g., Aberg et al., 2001, Aberg and Matarazzo, 1980, Aberg and Robinson, 1982. Dr. Hanff appears to have introduced the concept. Dr. Aberg has evolved it into the best-known empirically supported approach to child disruptive behavior in this country, perhaps in the world. We could say more about the contributions of these two remarkable people, but space forbids elaboration. This brings us to the target chapter by NZ and Aberg. It is the latest addition to the large body of literature that persuasively reveals the effectiveness and durability of PCIT. This literature shows that PCIT is definitely among the most rigorously tested parent training protocols, and perhaps the most empirically supported of them. The interested reader is referred to pttt//pcit.phhp.alpha.edu literature.htm for a comprehensive list of PCIT literature. For these reasons, it is at the top of the options that the many providers in our clinic select when they are preparing treatment plans for young children who exhibit clinically significant oppositional behavior. NZ and Aberg note that there are 4 other parent training interventions that are considered evidence-based and thus serve as additional treatment options for oppositional behavior. They are Helping the Non-Compliant Child, Forehand and McMahon, 1981. The Incredible Years, Webster Stratton and Reed, 2003, Parent Management. Training Oregon Model, Patterson, Reed, Jones, and Conger, 1975, and Positive Parenting Program, Sanders, 1999, C. Aberg, Nelson, and Boggs, 2008, for a more detailed description of empirical support. In the case described by NZ and Aberg, PCIT was aptly selected due to its classification as best practice for helping children to recover from the impact of abuse, Chadwick Center on Children and Families, 2004. In addition to the aptness of the treatment selection, there are several other virtues of the target chapter, but 4 are particularly noteworthy. The Phi-RST involves the clinical presentation of the participating child. The literature on reactive attachment disorder, RAD, is mostly descriptive, not wholly empirical, and the portion devoted to treatment is quite small. This paper provides clinicians with a practical conceptualization of RAD-associated treatment goals and a user-friendly guide for related treatment techniques. Although admittedly without an empirical basis, we do agree that increasing mutually reinforcing and responsive interactions between caregiver and child and decreasing coercive, aversive interactions is most appropriate given the attachment concerns. The second involves the extent to which the authors adapted to a highly complex set of socioeconomic conditions. Specify Cowley, there were three potential barriers to success in this case: ethnicity, socioeconomic status, SES, and generational difference, and all three were bridged successfully. Of the three, the most difficult in our experience has been generational difference. That is, tailoring parent-child interaction therapy. 19. Establishing adherence to parent training treatment requirements is difficult enough when working with a parent, but when working with a grandparent the difficulties multiply. This is especially true when the therapist is quite young. It is perhaps even more difficult when the therapist does not have a family of his or her own. Whether this is the case with the PhD author, we cannot say, but we suspect that NZ was significantly younger than her client. Despite the potential difficulties posed by this barrier and the others we have mentioned, the therapist, we assume it was NZ, obtained excellent compliance, which is almost certainly a testament to her skills as a therapist, but even more important, is a testament to the compelling nature of PCIT. Practical barriers such as transportation, difficulty, and serious financial problems are also difficult, and can waylay even the most experienced therapist. In this case, the therapist's success fully addressed the grandmother's transportation and financial needs without distracting from the pursuit of an effective therapeutic application. Balancing in-session demands is often tricky, and like the therapist in this case, we have found that having good social worker and community agency referrals can be a session saver. A third virtue involves a strategic modify cation to the conventional form of PCIT, which usually involves a version of timeout. Because of the special clinical presentation of the child involved, history of abuse, neglect, RAD, it was astutely determined by the therapist that the use of timeout may be harmful to the budding relationship between Alvin and his grandmother due to the often emotionally distressing nature of the procedures for both parent and child. Moreover, the treatment goals had been reached, making the more invasive disciplinary procedures unnecessary. We also speculate that for a child afflicted with RAD, consequential detachment could function as a reinforcer. For all of those reasons, placing emphasis on the child empowerment version of the therapy may be just what the doctor ordered, so to speak. And given the outcome, that appears to have been the case here. The fourth virtue brings us back to Doctors Hanf and Aberg's tremendous contributions to the treatment of childhood conduct problems from a social learning perspective. Specify Cowley, both emphasize objective data collection, particularly through behavioral observation techniques, which are a somewhat unique staple of parent training from a social learning perspective. Again, Dr. Hanf seems to have introduced the concept and Dr. Aberg has cemented it as a standard of practice. We cannot say enough about the value of objective data in clinical practice, and appreciate the comments on its use, from the assessment of Alvin's presenting problem and treatment progress to the assessment of Alvin's grandmother's skill acquisition. In closing, we both believe this is an excellent case report for the reasons mentioned above. Specify Cowley, it is one more tribute to the power of PCIT. And more Specify Cowley, it indicates that PCIT can be adapted to cross-generational, ethnic, and socioeconomic lines, and can be modified to fit special diagnostic characteristics. Thank you very much for inviting our opinion. 20. REFERENCES. Childhood Disorders. Chadwick Center on Children and Families. 2004, Closing the Quality Chasm in Child Abuse Treatment. Identifying and Disseminating Best Practices. San Diego, California, author. EYBERGS. M. FUNDERBURK, B. W. HEMBREEKIGIN, L. MCNEIL, C. B. QUERIDO, J. G. and Hood, K. 2001, Parent-Child Interaction Therapy with Behavior Problem Children, 1 and 2 year maintenance of treatment effects in the family. Child and Family Behavior Therapy, 23, 1-20. doi, 10.1300, J019V23 and 04_01 EYBERGS. M. and MATARAZZO, G. 1980. TRAININGPARENTSASTHERAPISTS. ACOMPARISON between individual parent-child interaction training and parent group didactic training. Journal of Clinical Psychology, 36, 492-499. EYBERGS. M. NELSON, M. M. and BOGGSS. R. 2008. EVIDENCE, BAS, EDPS, YCHOS, OCIALT, REAT. Ments for Children and Adolescents with Disruptive Behavior. Journal of Clinical Child and Adolescent Psychology, 37, 215-237. doi, 10.1080, 153744107018201117 EYBERG. S. M. and ROBINSONE. 1982. PARENTCHILDINTERACTIONTRAINING, EFFECTS on Family Functioning. Journal of Clinical Child Psychology, 11, 130-137. doi, 10.1080, 153744182095330766 FOREHAND, R. L. and MACMAHON, R. J. 1981. Helping the Non-Compliant Child, A Clinician's Guide to Parent Training. New York, Guilford Press. HANF, C. 1969. A two-stage program for modifying maternal controlling during mother-child, MC, interaction. Paper presented at the meeting of the Western Psychological Association, Vancouver, BC, Canada. HANF, C. 1970. Shaping Mothers to Shape Their Children's Behavior. Unpublished manuscript, University of Oregon Medical School. Portland, Oregon. HANF, C. And KING, J. 1973. Facilitating Parent-Child Interaction, a two-stage training. Model. Unpublished manuscript, University of Oregon Medical School. Portland, Oregon. P. TTERSON, G. R. REID, J. B. JONES, R. R. And CONGER, R. E. 1975. A Social Learning Approach to Family Intervention, Families with Aggressive Children, VOL. 1. EUGENEOR, Castalia. P. ED. S. ROBERTS. M. And FOREHAND, R. 1977. EVALUATIONOFTHEEFFECT, IV-ness of a standardized parent training program in altering the interaction of mothers and their non-compliant children. Behavior modify cation 1, 323 to 350. DOI 10.1177 014544557713003 ROBERTS M. W. MCMAHON R. J. FOREHAND R. And HUMPHREYS L. 1978. THEEFFECTOF Parental Instruction Giving on Child Compliance. Behavior Therapy 9, 793 to 798. DOI 10.1016 S0005-7894 78 80009-4 ROBERTS M. W. HATZENBUEHLER L. C. And BEANA. W. 1981. THEEFFECTSOFDIFFERE Entire attention and time out on child non-compliance. Behavior Therapy 12, 93 to 99. DOI 10.1016 S0005-7894 81 80109-8 Sanders M. R. 1999. Triple P Positive Parenting Program Towards an Empirically Valley. Dated Multilevel Parenting and Family Support Strategy for the Prevention of Behavior and Emotional Problems in Children. Clinical Child and Family Psychology Review 2, 71 to 90. DOI 10.1023 A 10218436133840. Tailoring Parent-Child Interaction Therapy. 21. Webster Stratton, C. And Reed, M. 2003. The Incredible Years Parents, Teachers, and Children Training Series. A multifaceted treatment approach for young children with CONDUCTP, ROBLEMS. INA. E. KAZDIN and J. R. WEISZ, EDS. Evidence-Based Psychotherapies for Children and Adolescents, pp. 224 to 240. New York, Guilford. DOI 0.1111 J.14753588.2007.00475.x. R. SPONSE. AMANDAM. NZIANDSHEILAM. EYBERG. In their assumptions that the PHI-RST author of our case study is a graduate student, young, not yet a parent, and Alvin's therapist, the commentators are 4 for 4. We thank them for their comments on this case. I, Aberg, also want to acknowledge NZ's clinical acumen. A fourth-year graduate student at the time, NZ had completed her clinical coursework and practica, had treated over 20 PCIT cases before working with Alvin, and recently received the Departmental Award for Psychotherapy Skill. PCIT is a difficult treatment to conduct, and Alvin's presentation was challenging. This case study indeed demonstrates NZ's skill, experience, and talent. In this response, I, Aberg, wish PHI-RST to clarify historical assumptions in the commentary. Unfortunately, I was not a student of Constance Hanff. I was a clinical psychology intern at the University of Oregon Medical School, UOMS, in the internship program directed by Arthur Weens. Hanff was on the faculty of the internship program at the University Affiliated Facility, UAF, directed by Ann Garner on the other side of campus. As the commentators note, Hanff mentored several UAF interns and postdocs, who subsequently developed treatments influenced by her mentorship, Barkley, Cunningham, forehand. Although I was not able to observe Hanff's work due to her sabbatical the year that I was an intern, 1971 to 1972, I learned about it from my internship mentor, H. Elizabeth King. Along with the writings of Diana Baumrind, 1967, Virginia Axline, 1947, and Gerald Patterson, e.g., Patterson and Gullion, 1968, Hanff's work, 1969, contrib. Used importantly to the development of PCIT during my internship and residency. At UOMS, C. Funderburg and Aberg, 2010, Aberg and Matarazzo, 1975. King moved to Georgia and published the PHI-RST studies of Hanff-influenced treatment with Forehand and King, 1974, Forehand, King, Pede, and Yoder, 1975. Since that time, generations of students have researched and refined the early treatments influenced by Hanff. Second, we wish to emphasize our clinical approach to the case of Alvin. As Fryman and Shaw suggest, this case provides an illustration of the flexibility of the evidence-based, manualized treatment protocols for children. Alvin's treatment followed the PCIT protocol with fidelity, while tailoring standard elements to meet the unique needs of this family. Tailoring refers to changes in the delivery. Tailoring parent-child interaction therapy. 23. Style of therapy elements and components to accommodate the individual sensibilities of each family, without altering the procedures themselves, Aberg, 2005, and it occurs with every family in treatment. In the case of Alvin, moving the toys to the table and focusing on attachment concerns during coaching are two examples of this approach. The decision to end treatment after CDI is another example of tailoring, based on our knowledge that Alvin's disruptive behavior was rated within normal limits by his grandmother, that she had mastered the CDI skills, and that her skills markedly changed the quality of interaction between the two. Her skillful application of contingent attention during the CDI was sufficient to manage the behavior problems that Alvin presented. Typically, caregivers opt to continue on to PDI to learn ways to apply contingent attention in the discipline interaction. In Alvin's case, however, the therapist and the grandmother decided that continuing to PDI was not the best course of action at this time. There is no evidence to suggest that a CDI-only protocol would be suitable for the entire RAD population, and we do not recommend such an adaptation at this time. In contrast to tailoring treatments for the individual family, treatment adaptations refer to changes in the core structure or content of the protocol for universal application to a specified C population, often a specified C diagnostic or cultural group, Aberg, 2005. To adapt an empirically supported treatment, ESD, requires well-conducted research showing that the adapted protocol works at least as well as the standard protocol, and has some additional benefit, such as greater acceptability in the new population, or greater effectiveness. Decades of research have documented the effectiveness of ISTs, and it is important to maintain the integrity of these treatments for the best clinical outcomes. We are indebted to the many researchers who over the years have dedicated their careers to the development and dissemination of ISTs for troubled young children. REFERENCES AXLINEV 1947. Play Therapy. Boston, Houghton Mifflin. Baumrind, D. 1967. Child Care Practices Anteceding 3 Patterns of Preschool Behavior. Genetic Psychology Monographs, 75, 43-88. Aberg, S. M. 2005. Tailoring and Adapting Parent-Child Interaction Therapy to New Populations. Education and Treatment of Children, 28, 197-201. EYBERG, S. M. and MATARAZZO, R. 1975, APRIL. Efficiency in Teaching Child Management Skills, Individual Parent-Child Interaction, Training versus Group Didactic Training. Paper presented at the meeting of the Western Psychological Association, Sacramento. FOREHAND, R. and KING, H. 1974. PRESCHOOLCHILD RENSNONCOMPLIANCE Short-Term Behavior Therapy. Journal of Community Psychology, 2, 42-44. FOREHAND, R. KING, H. PEED, S. and YODER, P. 1975. MOTHERCHILDINTERACTIONS. Comparison of a non-compliant clinic group and a non-clinic group. Behavior Research and Therapy, 13, 79-84. 24. Childhood Disorders. FUNDERBURK, B. W. and EYBERG, S. M. 2010. HISTORYOFPARENTCHILDINTERACTIONTHERAPY INJ. NORCROSS, ED. History of Psychotherapy, Continuity and Change, 2nd ed., pp. 415-420. Washington, D.C., American Psychological Association. HANF, C. 1969. A two-stage program for modifying maternal controlling during mother-child, MC, interaction. Paper presented at the meeting of the Western Psychological Association, Vancouver, BC, Canada. P. TTERSON, G. R. and GULLION, M. E. 1968. Living with Children, New Methods for Parents and Teachers. Champaign, Illinois, Research Press. 20. KEVINM. ANTSHEL. Pat, note that a pseudonym has been used to maintain confidentiality, is a 21-year-old Caucasian male who was court-ordered for evaluation for treatment. Since age 15, Pat has had multiple legal infractions, including several substance-related charges. His most recent legal charge, driving while impaired, prompted the current referral. At the time of referral, Pat was living with his mother, was employed part-time as a pizza delivery person, and was not currently enrolled in college. He was not engaged in any type of treatment at the time of referral. Pat was diagnosed with attention deficit, a hyperactivity disorder, ADHD, at age 7. The case of Pat represents a fairly typical case of a young adult who was diagnosed with ADHD in childhood. This case may or may not be applicable to those individuals who were initially diagnosed with ADHD during adulthood. Pat, childhood. Pat was born full-term, the product of a planned pregnancy. He attained his developmental milestones in an age-appropriate fashion. As a toddler, Pat was described as an active child who had a great imagination. With peers, he was described as bossy and could be stubborn nonetheless. He had a keen interest in social relations and was described as a social butterfly. At home, Pat could be oppositional and or defiant, but his mother reported that he responded very well to point systems and other strategies rooted in operant conditioning. During early elementary school, Pat's teachers had concerns regarding his abilities to exert self-control and complete tasks. Negative peer exchanges, often escalating to aggression, became more common in second grade, age 7. At the request of his school, Pat was referred for a mental health evaluation. His parents were still married at the time of this evaluation. While his mother was concerned about his behaviors and difficulties with authority, his father was less concerned. 26. Childhood disorders. And believed that many of Pat's difficulties were a function of a poor child-teacher match. Based upon the evaluation, Pat was diagnosed with ADHD, combined type, and oppositional defiant disorder, ODD. In addition to the standard psychiatric evaluation, the school district also completed a psychoeducational evaluation. Results from that evaluation documented that Pat had above average intellectual potential, Wechsler Intelligence Scales for Children 3, WISC 3, full-scale IQ equals 119, with especially strong perceptual for spatial skills, WISC II perceptual organization skills standard score equals 130. Pat's academic attainment was similarly described as above average for age. The school appropriately concluded that Pat's difficulties at school were not a function of a learning disability. While a combined psychosocial and pharmacological treatment plan was recommended by the mental health professional, Pat's parents did not wish to medicate their son. His parents did, however, enroll him in a social skills treatment group. In addition, Pat and his parents also participated in family therapy aimed at improving family functioning. Pat completed the social skills group with limited improvement. In fact, his mother reported that Pat learned new ways to be devious by observing other children in the group. In addition, family therapy was discontinued after several months due to increasing conflict ICT between Pat's parents. Much of the conflict ICT between his parents was attributed to Pat and his difficulties. For the remainder of elementary school, Pat was not engaged in any type of ADHD or mental health treatment. While he continued to excel academically, his behavior and peer relationships at school both continued to be impaired. Pat, early adolescence. Pat attended a new school for 5th grade, after having completed K-4 grades at the same elementary school. This transition brought with it new teachers and some new students. While Pat did not switch school districts, the middle school was fed by several different elementary schools. These new faces and the transition proved to be very difficult for Pat. Within the first month of school, Pat's parents were getting almost daily phone calls from his school regarding disruptive behaviors. Academically, despite having made strong progress in elementary school, Pat's grades slipped considerably in middle school. He was having great difficulties managing the increased independence that was expected from a middle school student, e.g., changing classes, planning for assignments. It was also at this time that his parents' marriage dissolved and his mother filed for divorce, seeking and being awarded uncontested sole custody of Pat. As a function of Pat's escalating disruptive behaviors and weaker school performance, as well as the stresses associated with the divorce, his mother sought to once again enroll Pat in some form of mental health treatment. Pat was once again diagnosed with ADHD and ODD. Once again, a combined treatment program was recommended to his mother. His school was considering moving Pat. Attention deficit, the hyperactivity disorder, ADHD. 27. To an alternative classroom that would be better suited to manage his disruptive behaviors. Possibly frightened by this possibility, Pat's mother discussed the use of medication with his pediatrician. Pat was prescribed methylphenidate, initially 5 mg bid, then titrated to 10 mg bid. At the urging of Pat's school psychologist, his mother also participated in a parenting class offered at a local mental health clinic. Finally, his pediatrician also recommended that Pat participate in therapy with a local psychologist. His mother reported that Pat instantly responded to the medication and was almost like a different boy. His teachers also noted the improvement, and his grades reflected their impressions. Pat went from a C student to an A student, largely as a function of simply completing and turning in all of his homework assignments. His mother was also learning more effective ways to manage Pat at home behaviorally. She implemented a point system with a response cost component. His therapist reported that Pat was more vocal about his feelings toward his father and was learning new, more adaptive methods to manage his anger. While the improvements in Pat's functioning were exciting, his mother was also increasingly concerned about his poor appetite and problems getting to sleep. In addition, his mother was concerned about his mood swings in the late afternoon when he was coming off his stimulant medication. Pat lost several pounds during the second half of his 5th grade year. At the urging of his pediatrician, his mother did not continue to give Pat his methylphenidate during the summer. His mother reported that many of his disruptive behaviors returned during the summer, although she also reported that he was somewhat more manageable than before. At the beginning of 6th grade, and unhappy with the continued side effects of the methylphenidate, Pat's mother discussed alternative medication options with his pediatrician. Pat was prescribed mixed amphetamine salts, 5 mg bid, then titrated to 10 mg bid. This medication similarly helped Pat exert better self-control and had fewer side effects. Nonetheless, even with the medication, his mother's improved parenting skills, as a function of completing her parenting class, and his continued bi-weekly therapy, Pat continued to have difficulties in school, both academically and socially. A review of his 6th, 7th, and 8th grade report cards all shared the same trends. Bright boy who could be doing much better if he applied himself, focuses more on social activities than schoolwork, disorganized, late for class, disrespectful to authority, and so on. Academically, Pat's cumulative averages were generally in the low 80s C with considerable between and within subject variability. High school again brought another change in school and with it new teachers, new students, and new expectations. As in his first year of middle school, Pat did not do well with the transition. His mother was getting almost daily phone calls about his behavior at school. In October of his 9th grade year, Pat was found to 28. Childhood disorders. Have marijuana in his school locker. Along with a 3-day suspension from school, he was required to participate in a substance abuse education program administered through the county. Pat also continued to be prescribed mixed amphetamine salts, but he was reportedly inconsistent in his adherence. There was also concern that Pat was diverting his stimulant medications to friends. Thus, a decision was made in February of his 9th grade year to try atomoxetine, initially 10 milligrams, then titrated up to 40 milligrams. While Pat was reported to have initially responded well to the Atomextine, over time, he and his mother were unsure if the medication was helping. Thus, at the end of his 9th grade year, he discontinued his atomoxetine. Pat and his mother both reported that he continued to use marijuana throughout high school. His mother was far more concerned about his marijuana use than Pat. He insisted that the marijuana helped me relax. Pat's friends were also regular marijuana users and were involved in other antisocial activities, e.g., shoplifting, egging houses, etc. In 10th grade, Pat had his Phi RST romantic relationship and sexual activity. Pat reported that he dated his Phi RST girlfriend for approximately 3 months, and that the relationship ended when Pat cheated on her with another classmate. Pat also reported having unprotected sex with both girls. Academically, Pat continued to earn low C grades across all subjects, and concerns continued to be raised about his poor academic motivation. He did not receive any ancillary supports, as it was felt that he could do the work if he wanted to. At the end of 10th grade, Pat decided that he no longer needed therapy and discontinued his bi-weekly therapy sessions. He also refused to take any ADHD medications. Thus, for both 11th and 12th grades, Pat had completely untreated ADHD. His academic performance and behavior at school dropped appreciably. Concerns were raised about Pat not being able to graduate unless significant improvements occurred. He attended summer school for 2 subjects, history, English, between 11th and 12th grades. He had weekly disciplinary referrals, most often for insubordination, with the occasional peer conflict ICT resulting in aggression. No drug charges were recorded during these 2 years, although Pat commented that he frequently attended school high from morning marijuana use. Pat's general trend was to wait until May to turn it on academically. With his native intelligence, Pat was able to get by and to eventually graduate high school. Pat graduated 341st in a class of 404 students. There was a general consensus from all of his teachers that he was capable of much more. His mother, however, was simply pleased to have her son graduate high school, commenting, "There were many days which I thought he would not do it." To no one's surprise, Pat had no interest in attending college. Instead, he looked for work and held several part-time jobs at local restaurants as a dishwasher. He often grew dissatisfied with the job and either quit or was asked to leave within the Phi RST few months. Pat eventually began working as a pizza delivery person, a job that he seemed to enjoy more. His co-workers were also regular marijuana users. Pat also began to experiment more with alcohol during this time period. Attention deficit, hyperactivity disorder, ADHD. 29. Pat's uncle, who was an instructor at a community college several hours away, began to have more considerable discussions with him about giving school another try. While Pat continued to express disinterest in school, he made a seemingly impulsive decision, 2 weeks before classes started, to matriculate at the community college and to live on campus. 2 days after his 19th birthday, Pat left home for the Phi RST time and moved into his dormitory room. Pat had a roommate whom he did not know, yet the two quickly became fast friends, sharing an interest in music, technology, and marijuana. Within 2 weeks, Pat was no longer attending classes and was partying quite often. Pat was found to have marijuana in his dorm room, was placed on disciplinary probation, and was asked to attend counseling. Pat did well socially at community college, yet when he attained a 0.8 GPA, his mother refused to have him return for the spring semester. Pat still refers to his community college experience as the best 3 months of my life. Pat returned home, lived with his mother, and resumed his job at the pizza restaurant. The relationship between Pat and his mother had soured considerably, such that his mother began taking an antidepressant. Pat continued his lifestyle and had several girlfriends during this time period. In an attempt to improve their relationship, his mother allowed one of his friends to move into their home. After living with them for several months, the friend had sexual relations with Pat's girlfriend. Pat became so enraged that he punched a brick fireplace, breaking several bones and requiring surgery to repair his hand. Pat continued to use marijuana, almost daily, and was drinking alcohol excessively. Several months before his 21st birthday, Pat left work at the pizza shop with friends and went to a local bar. Pat and his friends all had fake IDs and were able to order mixed drinks. Pat left the bar and was stopped by a police officer on the drive home. One of Pat's friends had OxyContin pills on his person and hastily threw the pills into the car glove box. When the officer searched the car and found the pills, the friend refused to acknowledge that the pills were his possession. Pat was arrested for driving while impaired and possession of a narcotic. Pat spent the night in jail, and his friends were escorted home by the police. Pat was found guilty of DWI and was court-ordered to substance abuse treatment. Once the substance abuse therapy was completed, his mother encouraged the substance abuse therapist to suggest to the judge that Pat be mandated to continue with ADHD-focused treatment, her words. The judge, who reportedly has a daughter with ADHD, agreed, mandating Pat to enter ADHD-focused treatment. This is around the time that I Phi RST meet Pat. Key principles of core knowledge. ADHD is one of the most prevalent, 5% of the childhood population, APA, 2000, well-researched and validated childhood psychiatric disorders, Goldman, Jennell, Besman, and Slanetz, 1998. Once considered exclusively a childhood condition, Hill and Schoner, 1996, much research suggests that ADHD persists into 30. Childhood disorders. Adolescence and adulthood for roughly 60% of the population, Barkley, Murphy, and Fisher, 2007, Farran, Biederman, and Mick, 2006, Manuza, Klein, Bessler, Malloy, and Lapadula, 1993. ADHD is a highly heritable condition. Average heritability index equals 0.76, Farran et al., 2005. Family studies of pediatric ADHD suggest that the parents of children with ADHD are more likely than parents of non-ADHD children to have ADHD themselves, Farran, Biederman, and Milberger, 1994. The same holds true in adult ADHD. offspring of parents with ADHD are more likely to have ADHD themselves. Biederman et al., 1995, Mans Hardy, Lippman, O'Daniel, and Blackman, 1983. For example, Biederman et al., 1995, found a 57% prevalence of ADHD among children of ADHD adults, much higher than the 15% prevalence of ADHD among siblings of ADHD children. Pediatric ADHD commonly co-occurs with multiple psychiatric disorders, including mood, anxiety, and disruptive behavioral disorders. Angold, Costello, and O'Canley, 1999, Biederman, Newcorn, and Sprich, 1991. Likewise, adult ADHD is also associated with comorbid mood, anxiety, and substance use disorder diagnoses. Barkley et al., 2007, Biederman et al., 1993, Borland and Heckman, 1976, Heiligenstein, Cunius, Burns, and Miller, 1998, Murphy and Barkley, 1996, Shikim, Asano, Hess, Zoucher, and Wheeler, 1990, Thompson et al., 2005. By definition, inattentive and/or overactive and impulsive symptoms have to impair the child's functioning in 2 or more domains to meet the criteria of the Diagnostic and Statistical Manual of Mental Disorders, 4th edition, text revision, DSM-IVTR. In children, educational, social, and family domains are often functionally impaired by ADHD symptoms. MTA Collaborative Group, 1999. Significant functional impairment in educational, marital, interpersonal, occupational, and motor vehicle operation realms is common in adult ADHD. Murphy and Barkley, 1996, Schubiner et al., 2000, G. Weiss, Hechtman, Milroy, and Perlman, 1985, Weilands and Dodson, 2004. In fact, Barkley's longitudinal research indicates that ADHD in adults is a more impairing disorder than many other disorders, e.g., anxiety disorders, mood disorders, etc., across multiple domains of major life activities, especially educational and occupational functioning, money management, and management of daily responsibilities. Barkley et al., 2007. ADHD-TRE at MENTS. There are ample data in the pediatric ADHD literature to support the efficacy of stimulant medications. MTA Collaborative Group, 1999. Approximately 70% of children with ADHD will demonstrate a therapeutic response to stimulant medications. For reviews, see Biederman et al., 1996, Farran, 2003. The adult ADHD data, Biederman et al., 1995, Biederman, Farran, Monutos, Bobber, and Cadigan, 2004, are strikingly similar and suggest that the majority, 74%, of adults with ADHD will demonstrate a therapeutic response to stimulant medications. The same pharmacological agents that are efficacious in the pediatric ADHD literature have also been demonstrated to be effective in adults with ADHD. Attention deficit, hyperactivity disorder, ADHD. 31. Methylphenidate, amphetamines, and lisdexamfetamine are stimulants that are FDA approved. Atomoxetine is a non-stimulant that is FDA approved for managing ADHD. Both the stimulants and atomoxetine improve core symptoms of hyperactivity, inattention, and impulsivity. Adler et al., 2008, Spencer et al., 2005, Spencer et al., 1998. Adults with ADHD are more likely to require polypharmacy than is the case for childhood ADHD. Adler, Reingold, Morrill, and Weilands, 2006, M. Weiss and Hechtman, 2006, Wendia, Wolf, and Wasserstein, 2001. While the stimulants and atomoxetine are more commonly prescribed for ADHD, bupropion, modafinil, and desipramine have also been described as efficacious for managing adult ADHD. Biederman et al., 1996, Taylor and Russo, 2000, Weilands et al., 2005, and may be used as second-line agents. Bupropion has demonstrated efficacy in open, Wendia and Reimher, 1990, and controlled, Kuperman et al., 2001, Weilands et al., 2005, studies and may be particularly efficacious in adults with ADHD who have comorbid mood disorders. Davis et al., 2001. In addition to pharmacotherapy, and similar to managing ADHD in children, a psychosocial treatment component is generally recommended. Dodson, 2005. Neither cognitive behavioral therapy, CBT, nor cognitive therapy has much research support in pediatric ADHD. Abakoff and Gittelman, 1985, Bayer and Neitzel, 1991, Bloomquist, August, and Ostrander, 1991, DuPaul and Eckert, 1997, Dush, Hurt, and Schroeder, 1989. For example, meta-analyses of CBT for children with ADHD have typically reported the effect sizes to be less than one-third a standard deviation. Bayer, 1991. Due to its limited efficacy with children, CBT was not included in the NIM multimodal treatment study of children with ADHD, MTA, treatment protocols. Although CBT has not been demonstrated to be efficacious in children with ADHD, there are reasons to be optimistic that CBT may be more efficacious in adults with ADHD. For example, CBT is generally more effective in adolescents relative to pre-adolescents. Holmbeck, Greenlay, and Franks, 2003. Similarly, in the adult ADHD literature, there is some evidence that CBT is efficacious for reducing functional impairments in patients also being treated with stimulants. Safran et al., 2005, Safran et al., 2010. ASSESSMENTSTRATEGY. At the time of referral, Pat was rather resistant to treatment and stated on several occasions that he was only coming here because some judge said, I have to be. After a failed attempt at college, Pat had been living with his mother for several years and was employed part-time as a pizza delivery person. He was not engaged in any form of treatment and was quite opposed to any treatment, psychosocial or pharmacological, stating, I have been on just about every ADHD medication there is. I hate them all. Given that he was living with his mother, I asked both Pat and his mother to attend the intake assessment. I structured the intake assessment so that I 32. Childhood disorders. Met with Pat and his mother together for approximately 45 minutes. Meeting together allowed me to collect information regarding Pat's history and also to observe the relationship between Pat and his mother. Whenever working with a young adult such as Pat, if possible, I attempt to gain collateral information from a parent. In my experience, young adults with ADHD are rather poor historians. During the initial 45-minute interview, it became clear that Pat and his mother had a negative relationship. This is not to say that Pat's mother was not appropriately concerned for her son, nor to infer that Pat and his mother did not have a good emotional bond. Rather, the negative relationship can be better characterized as a push-pull relationship. Pat perceived his mother as a nag who was always on my back. Conversely, his mother perceived Pat as lazy, unmotivated and selfish. She pushes him, he pulls away. During this initial 45-minute interview, it also became evident to me that Pat's mother quite possibly also had ADHD, although she had not been diagnosed with the disorder. At the time of referral, Pat's mother had been prescribed an SSRI, selective serotonin reuptake inhibitor, for mood and anxiety concerns, most of which she attributed to Pat. Pat's parents had divorced when he was 11 years old. His father continued to live near Pat, and his mother yet did not have regular contact with either. In addition, neither Pat nor his mother had a positive relationship with Pat's father. Given both of these facts, limited involvement, negative relationship, a decision was made not to invite Pat's father to the intake assessment or involve him in treatment. After spending some time with Pat and his mother was asked to go to the waiting room to complete several behavioral rating scales commonly used by our clinic to gather collateral information. These scales include the Adult Behavior Checklist, Achenbach, 2007, World Health Organization, Adult ADHD Scale, ASIS, Kessler et al., 2005, and Impairment Rating Scale, Fabiano et al., 2006. These scales were chosen for adults with ADHD. Different scales are employed for children and adolescents with ADHD. While his mother was completing the rating scales, Pat was interviewed using the structured clinical interview for DSM-IV disorders, SCID, First, Spitzer, Gibbon, and Williams, 1997. Based upon the SCID, Pat met formal DSM-IV diagnostic criteria for substance abuse, marijuana, alcohol, and a mood disorder, not otherwise specify ED. Our program also supplements the SCID with the ADHD module from the Schedule for Affective Disorders and Schizophrenia for School-Age Children, Present and Lifetime Version, KSA-DSPL, Kaufman et al., 1997. The KSA-DSPL is used because the SCID does not have an ADHD module. Based upon his report, Pat also met DSM-IV diagnostic criteria for ADHD, combined type, both past and present diagnoses. This entire interview took approximately 90 minutes. At the conclusion of this 2-hour appointment, a feedback session was scheduled for the following week. Both Pat and his mother were encouraged to attend the feedback session. Attention Deficit for Hyperactivity Disorder, ADHD. 33. During the feedback session, diagnostic impressions were provided and a treatment plan was described. Pat met formal DSM-IV diagnostic criteria for ADHD, substance abuse, and mood disorder, not otherwise specify ED. Given that Pat had been cleared by his substance abuse program and was not deemed to need further services, our treatment plan was to include both a pharmacological and psychosocial treatment component geared more toward his ADHD diagnosis. While his mother was very excited and hopeful about the proposed treatment plan, Pat was less enthusiastic yet stated, "What choice do I have? I don't think any." After the feedback session, I also spoke privately to Pat's mother via telephone to follow up with her about my own observation that she may indeed have ADHD herself. His mother reported that all of my friends say the same thing. Given my therapeutic relationship with Pat, I referred her to another local clinician who specializes in ADHD for a diagnostic evaluation. Epidemiological considerations. I have been working with Pat, and occasionally with Pat and his mother conjointly, for just over 1 year. We have had 34 sessions together, meeting weekly in the beginning of therapy, for roughly the first 3 months, and then bi-weekly thereafter. Our program is a research program, and we collect a wide variety of data at the initial evaluation, see above. Nonetheless, one did not need the vast amount of data to reliably conclude that Pat continues to meet criteria for ADHD. In many ways, Pat is a rather prototypical young adult who was diagnosed with ADHD in childhood. In addition to his ADHD diagnosis, Pat met also formal DSM-IV diagnostic criteria for substance abuse, marijuana, alcohol, and a mood disorder, not otherwise specify ED. Pat was referred to our team psychiatrist, who prescribed extended-release bupropion, 100 mg initially, then titrated up to 200 mg. Pat's mother was referred to another local clinician who specializes in ADHD and was indeed diagnosed with ADHD herself. She was prescribed extended-release methylphenidate by her primary care physician. She was also counseled to keep the methylphenidate in a secure place, lest Pat have any ideas about diverting and misusing his mother's medication. Case formulation. My initial case formulation was that Pat had ADHD and comorbid substance abuse diagnoses and likely had many subthreshold dysthymic mood symptoms. I believe that my diagnoses were evidence-based because they relied on structured, valid, and reliable assessment instruments as well as collateral report. In my eyes, this was a relatively straightforward diagnosis, especially in light of the many. 34. Childhood disorders. Previous assessments that Pat has had, as well as the clear chronic nature of his impairing symptoms. Psychosocial intervention, overview. The psychosocial intervention was a cognitive behavioral treatment for adult ADHD developed by Safran et al., 2005, Safran et al., 2010. The Safran et al. CBT model involves components of motivational interviewing, practice, review, and repetition of learned skills and is composed of 3 core modules, in addition to 3 optional modules. Pat received all 6 modules, core plus optional modules. The FIRST 4-session core module involved psychoeducation, about ADHD, as well as training in organization and planning skills. The second 3-session core module focused on Pat learning skills to reduce distractibility. The third core module used cognitive restructuring strategies described by Beck, 1995, Modif IED to account for an ADHD population. This module was our longest module, and we spent far more sessions, 11 sessions, in this module than in the original Safran et al. manual. The Saffron et al. 2005 optional modules were also completed. These modules included sessions focused on reducing procrastination, improving communication skills, e.g., reducing interruptions, improving active listening, etc., and improving anger or frustration management. Again, given Pat's history, more time was spent in the improving anger or frustration management modules than originally proposed by Saffron et al. Handouts describing the topics covered were provided to Pat at the conclusion of each session. The handouts were provided in an attempt to encourage generalizability of the strategies to the real world. In addition to relying on Pat for information regarding his functioning and application of the skills, periodic conversations with Pat's mother were also included. ITIALSESSIONS. While the Saffron et al. Module begins with direct intervention aimed at improving organization and planning, a common starting point for my work with young adults is increasing motivation. Stated another way, part of my job is convincing the young adult that there is a problem. While this may be a clinical reality for many mental health workers, this is a very common phenomenon for those of us who work in the ADHD-Phi ELD. In fact, many authors have commented on the positive illusory bias PIB, which reflects an overestimation of perceived abilities relative to actual level of ability and competence. Kanu and Carlson, 2007, Hoser, Washbush, Pelham, Molina and Milik, 2000, Owens, Goldfie Eni, Evangelista, Hoser and Kaiser, 2007. In other words, the individual with ADHD views things as better than they really are. This has patent connections to motivation, or lack thereof, for therapy. If you do not perceive that there is a problem, why would anything need to be changed? Thus, much of my initial work with Pat consisted of applying motivational interviewing. Attention deficit, or hyperactivity disorder, ADHD. 35. Techniques and concepts in an attempt to move him toward sensing a need for change. It certainly helped when his girlfriend at the time broke up with him, citing his anger and jealousy as primary reasons. These real-world gifts became a means to enhance motivation, albeit in a slower fashion than I would have liked. Saffron et al. Core modules. Once some motivation for change had been established, we began the Saffron et al. Core modules. As a general rule, my goal is to have the young adult and I talk roughly the same amount, i.e., Pat talks for 50%, I talk for 50%. Directing the session is a general practice in most forms of cognitive behavioral therapy, Blaggis and Hilsenroth, 2002, yet working with individuals with attention lapses has taught me to nurture a great amount of conversational give and take rather than long, one-sided discussions. This style is present throughout my work with the individual with ADHD, not only during the initial sessions. The Phi-RST module in the Saffron et al. Protocol focuses on psychoeducation about ADHD. In our program, we focus on describing ADHD from a biopsychosocial perspective. We also focus a great deal on the functional impairment criterion in ADHD, in an attempt to lessen the relatively common viewpoint, in my opinion, that ADHD is a benign condition. The organizational and plan. NING skills components include very concrete interventions such as having Pat purchase a planner. In our program, we make a great distinction between a planner, which tells us when we will do something, and a calendar, which tells us when something is due. We stress the importance of having a planner, not a calendar. Other organizational strategies are covered, including the importance of doing things in a routine fashion, e.g., always putting your keys in the same place, always charging your cell phone before you go to sleep at night, etc. This module with Pat accounted for 4 sessions, which, in my experience, is fairly typical for young adults with ADHD. The second Saffron et al. Module focused on lessening distractions. We focused on breaking larger tasks down into smaller chunks, using timers or alarms to help monitor time, estimating how long a task will take and then assessing his estimate, and keeping a list in his front pocket to help him write down a task rather than interrupting his ongoing task. These strategies were covered over the course of 3 sessions. Considerable motivational interviewing continued to be a prominent focus of the sessions. The third module was our longest module to date, consisting of 11 sessions. We covered errors in thinking using a structured sheet providing the most common errors in thinking based upon Beck's work. Pat was asked to identify which errors he makes more regularly. In addition, his mother was consulted for her perspective on what she observes and or hears from Pat. The concept of simple awareness of the automatic errors in thinking was covered by RST. After enhancing his awareness of his own self-talk, we focused on fighting back against the thoughts using cognitive restructuring techniques. 36. Childhood disorders. At this point, I had been working with Pat in therapy for approximately 4 months, and we had held 20 sessions. Pat had missed 1 appointment and had been late to 2 others. Over the course of the Phi-RST 20 sessions, predominantly weekly, Pat had gradually become more verbal and engaged in therapy. He also appeared to be having a therapeutic response to the bupropion. Nonetheless, attention problems persisted, especially being easily distracted. Thus, a decision was made by our program psychiatrist to start lisdexamfetamine, initially 30 mg, then titrated to 50 mg. While Pat reported limited changes in his real-world functioning, his mother was reporting far more optimistic progress. She reported that she and Pat were arguing far less often, and that Pat was less emotionally impulsive and more responsible, e.g., Pat did laundry last week. I did not even know that he knew how to do laundry. Having a young adult and parent, or spouse, disagree about the efficacy of treatment is not uncommon in my experience. Moreover, the direction of the difference is not consistent across cases. Saffron et al. Optional modules. Reducing procrastination and improving communication skills, e.g., reducing interruptions, improving active listening, etc., were each covered in 2 sessions. In addition to the core Saffron et al. Strategies for reducing procrastination, the concept of how we advertise activities, tasks, and so on, to ourselves was included. The goal was to get Pat to become more aware of the power of advertising in helping him to either choose to complete the task or not. The improving communication skills module involved a great deal of role-playing various scenarios. In addition, we walked through the hospital one day with the expectation that Pat would initiate and sustain conversations with strangers in the hospital. He seemed to enjoy this task immensely. The Phi Now Saffron et al. Optional module focused on improving anger or frustration management. This was a challenge initially, as Pat had made progress such that his frustration level was less than it had been 9 months prior. However, once again, a real-world change, another girlfriend breakup, helped bring the need for anger management back into focus. While Pat was able to very clearly describe how he should manage his anger, Pat continued to have difficulties managing his anger. Thus, his poor anger management was not a knowledge deficit, but more of a performance deficit. While we continued to role-play anger management strategies and focus on very concrete strategies, e.g., recognizing when is or is not a good time to have an argument, Pat continues to struggle to effectively manage his anger. In my opinion, and while not specify C to ADHD, Pat's poor anger management abilities are his most enduring symptom, sadly seeming recalcitrant to my best interventions. NONSPECIFICFACTORS. A considerable amount of clinical attention was devoted to the non-specify C factors of therapy, especially establishing a strong therapeutic alliance and promoting attention deficit, the hyperactivity disorder, ADHD. 37. Optimism and hope for change. The Phi RST several weeks of therapy was simply focused on establishing rapport with Pat and attempting to connect with him, relying heavily on motivational interviewing techniques, such as empathetic responding, providing feedback, and providing choices. As mentioned previously, Pat was not especially pleased to be in therapy and had participated in many previous psychological therapies. One of my guiding influences in establishing therapeutic alliance was getting a sense of these previous therapies, what worked and what did not, and attempting to integrate features of previous therapies that had been somewhat successful. I explicitly avoided arguments with Pat and attempted to roll with resistance rather than confronting him. Providing optimism and hope for change manifested itself through our very detailed discussion of the CBT framework and how CBT may be more effective for adults than children. Given that Pat did not really see a need for change, I once again relied heavily on motivational interviewing techniques to attempt to lessen Pat's ambivalence toward therapy. POTENTIALPROBLEMS. Missed appointments and arriving late to appointments are very common in adults with ADHD. Thus, our program spends considerable time at the beginning of the treatment covering our attendance policy. After 3 missed appointments, without calling 24 hours ahead to cancel, the person is automatically discharged. Given that Pat was court-ordered to treatment, he was well aware that discharge would not be in his best interest. Lack of commitment should be almost assumed in those that are court-ordered for treatment. Thus, right from the start, motivational interviewing techniques were heavily integrated into my treatment with Pat. Using the impairment rating scales, IRS, Fabiano et al., 2006, as our standard metric for assessing clinical response, Pat has modestly improved his functioning. We have modified the IRS to include a self-report version for adults. In both the parent and self versions, reporters are instructed to rate the severity of the young adult's problems in each domain and the need for treatment using a 7-point Likert scale. 0 equals no problem, a definitely does not need treatment. 6 equals extreme problem, a definitely needs treatment. At the beginning of treatment, 34 sessions ago, Pat's mother rated him as having an average of 4.6 on the assessed domains: relationship with peers, relationship with parents, self-esteem, occupational functioning, influence on family functioning, and overall impairment. At this point in therapy, Pat's mother rated him as having an average of 3.0 on the assessed domains. Pat's ratings are 3.0 and 1.9, respectively. Thus, from both perspectives, Pat is functioning better. However, a IRS rating of 3.0 does not represent normal functioning. Likewise, while Pat has not been arrested in the past year and has tested negative for marijuana at his 5E most recent drug tests, mandated through his court-ordered treatment, Pat continues to have the same job, pizza delivery, and loses his temper quite frequently with coworkers. 38. Childhood disorders. The goal for Pat moving forward is to help him continue to navigate the transition to adulthood. The transition to adulthood is defined by young adults themselves as accepting responsibility for oneself, gaining autonomy and independence, and becoming financially independent. Arnott and Taber, 1994. Shanahan, 2000. In many ways, these attributes and qualities are often very different for individuals like Pat, who have been diagnosed with ADHD. For example, Pat has talked previously about moving out of his mother's home, enrolling at a local community college, and requesting a promotion at work. At this point, none of the above has come to fruition or, frankly, has even begun to head in that direction. If the above-mentioned data did not suggest that Pat was improving, I would not continue to press ahead with the Saffron modules. Rather, I would take a step back and rely more heavily on motivational interviewing techniques. I would also attempt to engage more of Pat's natural social supports, mother, girlfriend, etc., in the context of therapy. Ethical considerations. The issue of confidentiality, the privacy need always be considered for young adults who are not functioning like young adults. Thus, at the beginning of treatment, I attempt to secure release of information in order to be in ongoing contact with parents or others who may function like parents, e.g., uncles, supervisors, teachers. Having parents attend the Phi RST session and provide historical information generally improves the likelihood that the young adult will consent to having parents involved in the therapy. I certainly respect the wishes of those who do not wish to release information to parents, yet in my work with young adults with ADHD, this is a relative rarity. In fact, it is usually the parents who refer the young adult for treatment in the Phi RST place. Common mistakes to avoid. The most fundamental mistake that I attempted to avoid was assuming that Pat's childhood diagnosis was still his adult diagnosis. By having a very structured and intensive assessment process, we attempt to avoid rubber stamping diagnoses simply based on what childhood condition may have been diagnosed. Another common mistake that I attempted to avoid in treatment was passively reinforcing Pat's marijuana use. Each time that Pat discussed his marijuana use, I quickly shifted into motivational interviewing techniques, attempting to get him to lessen his ambivalence toward his marijuana smoking. Relapse prevention needs to be included in any treatment plan for a young adult with ADHD and comorbid substance abuse. ADHD itself is often defined by inconsistencies in performance and functioning. Thus, setbacks along the way are almost a guarantee. Having this mindset has helped me to be curious, not attention deficit, hyperactivity disorder, ADHD. 39. Furious when the inevitable relapse occurs. Continuing to reinforce previously learned skills, e.g., using planners, keeping a list, etc., has also helped to lessen relapses. Misconceptions that some may have about CBT include viewing the therapy as a mechanical cookbook approach. While this approach may be true for some CBT practitioners, I wholeheartedly believe that there is much art to the practice of CBT. Knowing when to push forward, step back, and digress from the manual are all learned with CBT experience. By no means do I consider myself a master clinician in CBT, nonetheless, over the years in which I have been practicing CBT, I have become much more aware of the art that is involved in practicing competent CBT. Basic issues such as the pacing of the session, tone of voice, and digression from the manual by providing analogies, metaphors, and so on, all go heavily into my CBT practice. Nonetheless, at the core of my CBT practice remains the science. In conclusion, I view Pat as a rather prototypical young adult who was diagnosed with ADHD as a child. Certainly, there are less impaired young adults with ADHD who do not require the level of intervention that Pat has received. I certainly could have chosen these young adults to describe and made myself out to be a better clinician than I may actually be. However, the decision to present Pat was quite easy for me. I believe that Pat represents both the challenges of treating this population as well as the clear need for treating this population. In my opinion, ADHD is not the relatively benign condition that the media often portrays. Refrences. Abakoff, H. and Gittelman, R. 1985. Hyperactive children treated with stimulants. Is cognitive training a useful adjunct? Archives of General Psychiatry, 42, 10, 953-961. ACHENBACH, T. M. 2007. Adult Behavior Checklist for Ages 18 to 59, ABCL. Burlington, Vermont, ACEBA. ADLERL. A. REINGOLD, L. S. MORILL, M. S. and WILENS, T. E. 2006. COMBINATIONPH, a Racotherapy for adult ADHD. Current Psychiatry Reports, 8, 5, 409-415. ADLERL. A. SPENCER, T. J. LEVINEL. R. RAMSEY, J. L. TAMURA, R. KELSEY, D. ETAL. 2008. Functional Outcomes in the Treatment of Adults with ADHD. Journal of Attention Disorders, 11, 720-727. ANGOLD, A. COSTELLOE. J. and ERKANLI, A. 1999. COMORBIDITY. Journal of Child Psychology and Psychiatry, 41, 57-87. APA. 2000. Diagnostic and Statistical Manual of Mental Disorders, 4THED, text revision. DSMIVTR. Washington, D.C., American Psychiatric Association. ARNETT, J. J. and TABERS. 1994. ADOLESCENCET, RMINABLEA, and DINTERMINABLE. WHENDOES Adolescence End. Journal of Youth and Adolescence, 23, 517-537. Bayer, R.A. and Neitzel, M.T. 1991. Cognitive and Behavioral Treatment of Impulsivity in Children, a meta-analytic review of the outcome literature. Journal of Clinical Child Psychology, 20, 400-412. 40. Childhood Disorders. B. I. RKLEY, R. MURPHY, K. and FISCHER, M. 2007. ADHD in Adults, What the Science Says. New York, Guilford Press. Beck, J. 1995. Cognitive Therapy, Basics and Beyond. New York, Guilford Press. B. DERMAN, J. FARAONES. MILBERGERS. GUITE, J. MICKE. CHENL. ETAL, 1996. A. Prospective 4-year follow-up study of attention deficit hyperactivity and related disorders. Archives of General Psychiatry, 53, 5, 437-446. B. 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 I. L. L. DERMAN, J. FARAONES. V. MICKE. SPENCER, T. WILENS, T. KIELY, ETL, 1995. High risk for attention deficit hyperactivity disorder among children of parents with childhood onset of the disorder, a pilot study. American Journal of Psychiatry, 152, 3. 431-435. DERMAN, J. FARAONES. V. MONUTEAUX, M. C. BOBER, M. And CADOGENE. 2004. Gender effects on attention deficit, a hyperactivity disorder in adults, revisited. Biological Psychiatry, 55, 7, 692-700. DERMAN, J. FARAONES. V. SPENCERT. WILENS, T. NORMAN, D. LAPEY, K. A. et al., 1993. Patterns of psychiatric comorbidity, cognition, and psychosocial functioning in adults with attention deficit hyperactivity disorder. American Journal of Psychiatry. 150, 12, 1792-1798. DERMAN, J. NEWCORN, J. And SPRICH, S. 1991. COMORBIDITYOFATTENTIONDE FICIT hyperactivity disorder with conduct, depressive, anxiety, and other disorders. American Journal of Psychiatry, 148, 5, 564-577. GYS, M. D. And HILSENROTH, M. J. 2002. DISTINCT, IVEACT, IVITIESOFCOG, and ITIVEBEHAVI oral therapy. A review of the comparative psychotherapy process literature. Clinical Psychology Review, 22, 5, 671-706. OMQUIST, M. L. AUGUST, G. J. And OSTRANDER, R. 1991. EFFECTSOFASCHOOLBAS, ED Cognitive Behavioral Intervention for ADHD Children. Journal of Abnormal Child Psychology, 1991-605. Borland, B. L. And Heckman, H. K. 1976. Hyperactive Boys and Their Brothers, a 25-year follow-up study. Archives of General Psychiatry, 33, 669-675. Carnu, W. H. And Carlson, C. L. 2007. Rejection Sensitivity and Social Outcomes of Young Adult Men with ADHD. Journal of Attention Disorders, 10, 3, 261-275. DAVISS, W. B. BENTIVOGLIO, P. RACUSIN, R. BROWN, K. M. BOSTIC, J. Q. And WILEY, L. 2001. Bupropion sustained release in adolescents with comorbid attention deficit, the hyperactivity disorder and depression. Journal of the American Academy of Child and Adolescent Psychiatry, 43, 307-314. DODSON, W. W. 2005. PHARMACOTHERAPYOFADULT Journal of Clinical Psychology. 61, 5, 589-606. Dupaul, G. J. and Eckert, T. L. 1997. The Effects of School-Based Interventions for Atten. Tyon Deficit Hyperactivity Disorder, a meta-analysis. School Psychology Digest, 26. 5-27. DUSH, D. M. HIRT, M. L. And SCHROEDER, H. E. 1989. SELFSTATEMENTMODI-5-cation in the treatment of child behavior disorders, a meta-analysis. Psychological Bulletin, 106, 1, 97-106. FABIANO, G. A. PELHAM, W. WASCHBUSCH, D. A. GNAGY, M. LAHEY, B. B. CHRONIS. A. M. et al., 2006. A Practical Measure of Impairment. Psychometric Properties of the Impairment Rating Scale in Samples of Children with Attention Deficit Hyperactivity Disorder and 2 School-Based Samples. Journal of Clinical Child and Adolescent Psychology, 35, 369-385. Attention Deficit, a Hyperactivity Disorder, ADHD. 41. FARAONES. BIEDERMAN, J. And MILBERGERS. 1994. ANEXPLORATO, RYSTUDYOFADHDAMO, and G. Second-degree relatives of ADHD children. Biological Psychiatry, 35, 398-402. FARAONES. V. 2003. UNDERSTA, and DINGTHEEFFECTS, IZEOFADHDM, EDICATIONS. I'm PLICATIONS for clinical care. Medscape Psychiatry and Mental Health, 8, 2. FARAONES. V. BIEDERMAN, J. And MICKE. 2006. THEAGE, DEPENDENTDECLINEOFATTENTIO and Deficit Hyperactivity Disorder, a meta-analysis of follow-up studies. Psychological Medicine, 36, 2, 159-165. FARAONES V PERLISR H DOYLEA E SMOLLER J W GORALNICK J J HOLM Gren M.A. et al., 2005. Molecular Genetics of Attention Deficit, a Hyperactivity Disorder. Biological Psychiatry, 57, 11, 1313 to 1323. First, M. B. Spitzer, R. L. Gibbon, M. and Williams, J. B. 1997. Structured Clinical Interview for DSM-IV Clinical Version, SCIDCV, User's Guide and Interview. Washington, D.C., American Psychiatric Press, Inc. GOLDMAN, L. S. GENEL, M. BEZMAN, R. J. and SLANETZ, P. J. 1998. DIAGNOSISANDT, REA, Treatment of Attention Deficit, the Hyperactivity Disorder in Children and Adolescents. Council on Scientific Affairs, American Medical Association. Journal of the American Medical Association, 279, 14, 1100 to 1107. HEILIGENSTEINE. CONYERS, L. M. VERNS, A. R. and MILLER, M. A. 1998. PRELIMINA, RYNO Armative Data on DSM-IV Attention Deficit Hyperactivity Disorder in College Students. Journal of American College Health, 46 of 4, 185 to 188. HILL, J. C. and SCHOENER, E. P. 1996. AGE, DEPENDENTDECLINEOF, ATTENTIONDE Ficid Hyperactivity Disorder. American Journal of Psychiatry, 153, 9, 1143 to 1146. HOLMBECK, G. E. GREENLEY, R. N. and FRANKS, E. A. 2003. DEVELOPMENTALIS SUES A and DCONSID RATIONSIN RES EARCHA and DP RACTICE INA KAZDIN J R WEISZ EDS Evidence-Based Psychotherapies for Children and Adolescents, pp 103 to 144. New York, Guilford Press. HOZA B WASCHBUSCHD A. PELHAM, W. E. MOLINA, B. S. and MILICH, R. 2000. Attention Deficit, Hyperactivity Disordered and Control Boys' Responses to Social Success and Failure. Child Development, 71, 2, 432 to 446. KAUFMAN, J. VIRMAHER, B. BRENT, D. RAOU. FLYNN, C. MORECI, P. ETAL. 1997. Schedule for Affective Disorders and Schizophrenia for School-Age Children Present and Lifetime Version, KSADSPL Initial Reliability and Validity Data. Journal of the American Academy of Child and Adolescent Psychiatry, 36, 7, 980 to 988. KESSLER, C. ADLERL. AMES, M. DEMLER, O. FARAONES. HIRIPIE, ETAL, 2005. The World Health Organization, Adult ADHD Self-Report Scale, ASRS, a short screening scale for use in the general population. Psychological Medicine, 35, 2, 245 to 256. KUPERMANS. PERYP. J. GAFFNEY, G. R. LUND, B. C. BEVERSTILLE, K. A. ARNDT, S, et al., 2001. Bupropion SR versus methylphenidate versus placebo for attention deficit hyperactivity disorder in adults. Annals of Clinical Psychiatry, 13, 3, 129 to 134. MANNUZZA, S. KLEIN, R. G. BESSLER, A. MALLOY, P. and LAPADULA, M. 1993. ADULTOUT. Come of Hyperactive Boys, Educational Achievement, Occupational Rank, and Psychiatric Status. Archives of General Psychiatry, 57, 565 to 576. MANSHADI, M. LIPPMANNS. ODANIEL, R. and BLACKMAN, A. 1983. ALCOHOLABUSEA and D Attention Deficit Disorder. Journal of Clinical Psychiatry, 44, 379 to 380. MTA Collaborative Group. 1999, a 14-month randomized clinical trial of treatment strategies for attention deficit, hyperactivity disorder. The MTA Cooperative Group. Multimodal treatment study of children with ADHD. Archives of General Psychiatry, 56, 12, 1073 to 1086. 42. Childhood disorders. MURPHYK and BARKLEYR. A. 1996. ATTENTIONDE FICIT hyperactivity disorder adults, comorbidities and adaptive impairments. Comprehensive psychiatry, 37, 6, 393 to 401. OWENS J. S. GOLDFINEM. E. EVANGELISTAN. M. HOZAB. And KAISERN. M. 2007. A critical review of self-perceptions and the positive illusory bias in children with ADHD. Clinical Child and Family Psychology Review, 10-4, 335 to 351. S. FRENS. A. OTTO. W. SPRICH. S. WINETT. C. L. WILENS. T. E. And BIEDERMAN. J. 2005. Cognitive Behavioral Therapy for ADHD in medication-treated adults with continued symptoms. Behavior Research and Therapy, 43, 7, 831 to 842. S. 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 FRENS. A. SPRICH. S. MIMIAGA. J. SURMAN. C. KNOUSEL. GROVES. M. Et al. 2010. Cognitive Behavioral Therapy versus Relaxation, with Educational Support for Medication-Treated Adults with ADHD and Persistent Symptoms, a randomized controlled trial. Journal of the American Medical Association, 304, 8, 875 to 880. HUBINER, H. TZELEPIS, A. MILBERGERS. LOCKHART, N. KRUGER, M. KELLEY, B. J. et al., 2000. Prevalence of Attention Deficit, Hyperactivity Disorder and Conduct Disorder among Substance Abusers. Journal of Clinical Psychiatry, 61, 4, 244 to 251. ANAHAN, M. J. 2000. PATHWAYSTOADULTHOODINCHA and GINGSOCIETIES, VARIABILITYA and D Mechanisms in Life Course Perspective. Annual Review of Sociology, 26, 667 to 692. EKIM, W, O. ASARNOW, R. F. HESSE. ZAUCHA, K. And WHEELERN. 1990. ACLI and ICL and demographic profile of a sample of adults with attention deficit hyperactivity disorder, residual state. Comprehensive Psychiatry, 31, 5, 416 to 425. ENCERT. BIEDERMAN, J. WILENS, T. DOYLER. SURMAN, C. PRINCE, J. ETL, 2005. A large, double-blind, randomized clinical trial of methylphenidate in the treatment of adults with attention deficit, the hyperactivity disorder. Biological Psychiatry, 57, 5, 456 to 463. ENCERT. BIEDERMAN, J. WILENS, T. PRINCE, J. HATCH, M. JONES, J. ETAL, 1998. Effectiveness and tolerability of tamoxifen in adults with attention deficit hyperactivity disorder. American Journal of Psychiatry, 155, 5, 693 to 695. TAYLORF. B. And RUSSO, J. 2000. EFI Casey of Modify nil compared to dextroamphetamine for the treatment of attention deficit hyperactivity disorder in adults. Journal of Child and Adolescent Psychopharmacology, 10, 4, 311 to 320. T. OMSON, J. A. TOLMIE, K. FOOT, H. C. WHELAN, K. M. SARVARY, P. And MORISON, S. 2005. INFL UNS of Virtual Reality Training on the Roadside Crossing Judgments of Child Pedestrians. Journal of Experimental Psychology Applied, 11, 3, 175 to 186. WEISS, G. HECHTMAN, L. MILROY, and PERLMAN, T. 1985. PSYCHIAT, RICSTATUSOFHYPER archives as adults. A controlled prospective 15-year follow-up of 63 hyperactive children. Journal of the American Academy of Child and Adolescent Psychiatry, 24, 2, 211 to 220. WEISS, M. And HECHTMAN, L. 2006. ARANDOMIZEDDOUBLE, BLINDT, IALOFPA, ROX, ETINEAND, or dextroamphetamine, and problem-focused therapy for attention deficit, a hyperactivity disorder in adults. Journal of Clinical Psychiatry, 67, 4, 611 to 619. WENDERP. H. And REIMHERRF. W. 1990. BUPROPIONTREATMENTOFATTENTIONDE hyperactivity disorder in adults. American Journal of Psychiatry, 147, 8, 1018 to 1020. WENDERP. H. WOLFL. E. And WASSERSTEIN J. 2001. ADULTSWITHADHD, ANOVERVIEW. Annals of the New York Academy of Sciences, 931, 1 to 16. WILENS T. And DODSON W. 2004. ACLINICALPE RSPECT IVEOFATTENTIONDE FICIT, a hyperactivity disorder into adulthood. Journal of Clinical Psychiatry, 65, 10, 1301 to 1313. WILENS T. E. HAIGHT B. R. HORRIGAN J. P. HUDZIAK J. J. ROSENTHAL N. E. CO Nor. D. F. et al., 2005. Bupropion XL in adults with attention deficit or hyperactivity disorder, a randomized, placebo-controlled study. Biological Psychiatry, 57, 7, 793801. C. Mentory. RUSSELLA. VARKLEY. Dr. Ansel describes an interesting and relatively typical case of a young adult referral in which ADHD has been previously diagnosed. Pat's history of repetitive antisocial behavior and occasional contacts with the legal authorities is, sadly, relatively commonplace in children with ADHD followed to adulthood. Barkley, Murphy, and Fisher, 2008, Saturfi ELD, Fowler, Cronella, Shell Swanson and Homer, 2007. This is particularly so for driving offenses, where available research shows teens and adults with ADHD to be at high risk for a variety of adverse outcomes. Barkley and Cox, 2007. Consequently, clinicians must take care to advise not only patients with ADHD, but parents as well about the driving risks of teens and young adults with ADHD under their care, and the need to take appropriate steps to address those risks, including the use of medication while driving. As in this case, antisocial activities or contacts with legal authorities may be the basis for the referral for evaluation and often are the most impairing and distressing feature of the current presentation, at least to the patient's loved ones, if not to the patient himself. And while ADHD, conduct disorder, CD, antisocial behavior, and psychopathy are distinct yet interrelated disorders of Constructs, Pardini, Obradovic, and Luber, 2006, and most cases of ADHD do not become adult psychopaths of Fowler, Langley, Rice, Whittinger, Ross et al., 2009. There is a greater likelihood of psychopathy in teens and adults with ADHD than is the case in the general population, especially if they had manifested symptoms of childhood conduct problems, Washbush and Willoughby, 2008. Given the strong contribution of psychopathic traits to persistence of antisocial behavior into and through adulthood, Fowler et al., 2009, Lynham, 1998, and the substan. Tile genetic and neurological contributions to psychopathy, Blair, Pochard. Bud Haney, Mitchell, and Pine, 2006, clinicians need to be on the alert for its existence in cases such as Pat's, as it may bode for an even poorer outcome than with ADHD or CD alone. It may also increase the risk of harm to family members and others attempting to intervene with the patient. Thus it might have been useful in this case to screen for such traits using rating scales for this purpose. Clinicians also need to appreciate the high risk that such cases of ADHD, antisocial behavior have for current and later drug use and abuse. This was clearly the case for Pat, starting in early adolescence. My own longitudinal study of children with ADHD followed to age 21 suggests that while earlier conduct. 44. Childhood disorders. Problems or disorders are clearly associated with later risks for predatory forms of antisocial behavior and with running away from home and teen prostitution. By age 21, ADHD was associated with later drug-related activities, such as possession, sale, and use of illegal drugs and theft, even after controlling for earlier CD. Barkley, Fisher, Smallish, and Fletcher, 2004. And once drug use was initiated, it interacted over time with antisocial behavior such that each exacerbated the other. That Pat should show some affinity for the use and abuse of marijuana is also not uncommon. We have found that adults who were diagnosed with ADHD as children and adult clinic-referred patients diagnosed with ADHD have higher rates of use of alcohol, tobacco, and marijuana than does the general population, or control groups. Barkley et al., 2008. Hence the need for substance use treatment programs is likely to be part of the treatment package recommended for such cases, as it was for Pat. And while not mentioned in Pat's case history, those using marijuana are likely to be using tobacco, and typically started with the latter drug RST, Barkley et al., 2008, perhaps, because the individual may find some therapeutic benefit from the nicotine, and thus may be self-medicating his or her ADHD. Collins, McClellan, and Fuemela, 2005. The limited or non-existent insight of Pat into his current problems, history of ADHD, and need for current treatment is a common occurrence. For instance, our longitudinal research found that only 4% of cases we previously diagnosed with the disorder in childhood reported sufficient symptoms to meet DSM diagnostic criteria. The majority saw themselves as not having the disorder and grossly underreported their symptoms. Barkley et al., 2008. As evidence of this fact, we found that the correlation between parent and patient report at age 21 was just 0.21 and at age 27 was just 0.43. Parental reports of symptoms were found to correlate more highly with impairment and with more domains of impairment than were self-reported symptoms at age 21, and thus parent reports were considered more valid. Barkley, Fisher, Fletcher, and Smallish, 2002. This striking disparity between parental reports and self-reported information in someone not self-referred for an evaluation of ADHD is commonplace, despite the patient having been diagnosed as a child. It supports the commendable practice by Dr. Ansel of interviewing the parent, or other collateral, who knows the patient well, in addition to the routine interview of the patient, and has led to this practice being considered as important to the evaluation of adults with ADHD, McGuff and Barkley, 2004. The significant level of distress and conflict ICT in the parent-offspring relationship, so palpable between Pat and his mother, is also typical of teens and young adults with ADHD, particularly when oppositional deficit and disorder and conduct problems exist in the patient. Johnston and Mash, 2001, Edwards, Barkley et al., 2001. In such cases, father absence is more common, or, if a father is present within the family unit, disengagement from the teen and even from the marriage may be likely. In my experience, this was certainly the case with Pat's father and removes one source of potential constructive influence from this situation. In such families, as Dr. Ansel ably discusses, the likelihood of ADHD in one or both parents is significant as a consequence of the striking heritability of the attention deficit, the hyperactivity disorder, ADHD. 45. ADHD traits. Clinicians should follow Dr. Ansel's lead in screening all parents of patients with ADHD in instances such as this one, and obviously in children and teens, in which the parent continues to play a substantial role in the life of the patient. The parent's ADHD may well interfere with not only the current adjustment of the patient, but also with efforts to implement treatment programs. Sonniger, Daly, and Thompson, 2002, for which the parent may have some direct or indirect responsibilities. Further evaluation of and treatment for the parent's ADHD, as was initiated in this case, is likely to prove beneficial not only for Pat's mother, but also for the treatment plan created for Pat as well. That a mild mood disorder, such as demoralization or dysthymia, was evident in Pat's case, and clearly noticeable in his irritability with his mother and the examiner, is likewise not surprising. Such disorders occur with greater frequency in both children with ADHD followed to adulthood, age 27, and adults with ADHD, who self-refer for clinical evaluations, Barkley et al., 2008. The linkage may arise, in part, from shared genetics between the disorders, Ferran and Biederman, 1997, as well as the common comorbidity between ADHD, CD, and depression, Angold, Costello, and O'Canley, 1999. Should the patient's demoralization have arisen as a consequence of his repeated failures and impairments in major life activities associated with his ADHD, it may well respond to management with ADHD medications. This is not likely to be the case for more serious mood disorders, such as major depression, for which separate treatments may be necessary. The limited or non-existent benefit of earlier treatments during childhood for ADHD on adolescent and young adult outcomes, as evident in Pat's case, is also relatively typical in the small literature that has examined the issue. Barkley et al., 2008, Molina, Hinson, Swanson, Arnold, Vitiello et al., 2009. This is not because treatments given in childhood do not have beneficial effects on children's ADHD or domains of impairment. Clearly they do. It is more likely due to the termination of these treatments over time, as was seen in Pat's case, such that by high school only a minority of ADHD cases who were previously treated continued on their medication, or in a combined medication, a psychosocial treatment program. The lesson here seems to be that for treatment to improve adolescent and young adult outcomes, it must be sustained through adolescence to young adulthood, as would be the case with any chronic medical condition such as diabetes. That is easier said than done with adolescents, as was clear in Pat's case. His resistance to taking medication as an adolescent and his later begrudging acceptance of it as a young adult are also quite typical, in my own experience. Adolescent non-compliance with ADHD medications thus makes intervening in these crucial adolescent years much more difficult than may be the case for children with ADHD, or for the management of adult self-referrals who are diagnosed with the disorder and are more cooperative with such self-sought interventions. Also noteworthy in Pat's history and current adjustment is his limited educational attainment, despite above-average intelligence and absence of a specified learning disability. Numerous longitudinal studies, including my own, have repeatedly documented the adverse impact of ADHD on eventual educational. 46. Childhood disorders. Attainment. 30 to 40% of childhood cases do not complete high school, and perhaps just 5 to 10% complete a college degree program, Barkley et al., 2008. This will obviously carry forward to have a detrimental effect on the level of occupation that such individuals can obtain at entry into the workforce, as well as on their upward advancement in their chosen occupation. A few comments on the approach to assessment used by Dr. Ansel seem in order. The use of adult ADHD rating scales for the initial screening for risk for disorder and especially to document the developmental inappropriateness of the symptoms, as was done here, is essential for establishing that the patient has met these aspects of diagnostic criteria for ADHD. McGuff and Barkley, 2004, Murphy and Gordon, 2006. Several rating scales, besides the Adler scale used here, have acceptable norms and are available for documenting DSM-IV symptoms of ADHD in adults. Barkley, 2011a, Connors, Earhart, and Sparrow, 1998. Also noteworthy was the attempt by Dr. Ansel to broadly screen for potential impairment in major domains of life activities, in this case adapting the child impairment scale initially developed by Fabiano. Symptom severity does not equate directly to related levels of impairment, requiring that impairment be assessed separately and specify clearly in such cases, rather than just inferring such. From the severity of the ADHD symptoms, Gordon, Ansel, Ferran, Barkley, Lewandowski et al., 2006, Lewandowski, Lovett, and Gordon, 2009. Problematic with the children's impairment scale, however, is the lack of validity and other psychometric information about the scale when used with adults, and the lack of norms for an adult general population sample. These problems have been addressed in a more recently published rating scale of impairment in adults that captures 15 major domains of life activities, Barkley, 2011b, that now would be a more appropriate alternative. Given that adults with ADHD often have associated deficits in various domains of executive functioning, E.F., Barkley et al., 2008, Hervey, Epstein, and Curry, 2004, I also encourage clinicians to incorporate some assessment of these functions in the evaluation of adults with ADHD. While this has been traditionally done using psychometric EF test batteries, such tests often fail to detect the difficulties in EF associated with ADHD, with just 25 to 50% falling in the impaired range on these tests. Barkley and Murphy, 2011, Biederman, Petty, Fried, Black, Doyle et al., 2008, Biederman, Petty, Fried, Fontanella, Doyle et al., 2006. Moreover, such tests have low or no ecological validity. This is to say that they correlate poorly, if at all, with either ratings of EF in daily life activities, or with measures of impairment in a variety of important domains of adult major life activities. Barkley, 2011 C, Barkley and Fisher, 2011, Barkley and Murphy. 2011, Barkley and Murphy, 2010. As a result, I do not recommend that clinicians waste their time with such a time-consuming psychometric test battery approach in cases of adult ADHD. More useful, economical, convenient, and ecologically valid is the use of rating scales of EF in daily life activities, such as the Deficits in Executive Functioning Scale Barkley, 2011 D, or Behavior Rating Inventory of Executive Functioning, adult version Roth, Isquith, and Joya, 2005. Note, however, that the latter scale may have the potential to over-identify EF deficits. Attention deficit, a hyperactivity disorder, ADHD. 47. In view of its relatively supernormal and technologically, psychiatrically, and medically Phi-altered normative sample, rating scales have greater utility than tests in predicting impairment. Barkley and Fisher, 2011, Barkley and Murphy, 2010, which makes them more pertinent to assessing issues of EF deficits in clinical settings where understanding and predicting such impairments is a major purpose of such evaluations. Such scales indicate that 86 to 98% of adults with ADHD are impaired in one or more domains of EF in daily life, such as self-organization and problem-solving, self-management to time, self-motivation, self-discipline, and self-regulation of emotions. Barkley, 2011 C. Another advantage to such EF rating scales, and those noted earlier for adult ADHD and impairment, is their convenience for monitoring response to interventions, as was done in Pat's case, using the ADHD and impairment ratings. Dr. Ansel commendably elected to use the most evidence-based interventions for Pat's ADHD, these being medication and cognitive behavioral treatment, CBT. Medications remain a mainstay, empirically based treatment for child and especially adult ADHD. See Prince, Weilands, Spencer, and Biederman, 2006, and so returning Pat to medication was a wise choice in this case, even if the patient complied grudgingly. Medications will likely be required for the management of 70 to 80% or more of adult cases, in my opinion, whether to treat the ADHD, or, as often is the case in over 80% of adults with ADHD, Barkley et al., 2008, to treat their comorbid disorders. While annoying side effects certainly exist with these medications, and their side effect profile clearly depends on whether stimulants, methylphenidate, amphetamine, non-stimulants, atomoxetine, or antihypertensives, guanfacine XR, clonidine XR, FDA approved, only for children to date, are utilized, the safety profile of these medications is unsurpassed in any other area of psychopharmacology for psychiatric disorders despite sensationalized media accounts to the contrary. The most common side effects, 30 to 50% or more of cases, for the stimulants are typically loss of appetite for midday meals primarily, along with insomnia, both of which tend to be more problematic for child than adult cases of ADHD. Some modest temporary cessation of gains in growth in children may occur, but these have not been documented to continue into late adolescence or adulthood. Perhaps 25% or fewer cases complain of stomachaches or headaches in conjunction with stimulant use. From 10 to 25% of cases do not respond to the starting medication type or delivery system, pills, or as pump, time-release pellets, skin patch, or prodrug, and may require switching to alternative delivery systems or medications before a good therapeutic effect is obtained. About 3 to 5% of cases may not be able to tolerate any dose of these medications. The CBT program by Safran and colleagues, Safran, Perlman, Sprich, and Otto, 2005, implemented with Pat is a Phi-NE intervention for adult ADHD with an increasing evidence base, Nows and Safran, 2010. Several similar programs that also have an evidence base are available for conducting CBT with adults with ADHD, Ramsey and Rostin, 2007, Salanto, 2010. All CBT programs focus on training adults in strategies to compensate for their deficits in executive functioning in daily life, such as difficulties with time management, organization. 48. Childhood disorders, problem solving, emotional self-control, and so on, as noted above. There is no consensus yet in the Phi-ELD as to the sequence in which the medication and CBT treatments ought to be instituted for an adult with ADHD. Safran and colleagues require their patients to be on medication before enrolling in CBT, as they believe that it makes them more likely to attend to and follow through on the treatment procedures than if they are off medication, a point with which I agree. Ramsey and Rostin strongly encourage a combined intervention as well. The Salanto program has been studied with patients being off medication and has had some success as well, but it is not clear whether more improvement might have been evident had patients also been on an ADHD medication. Given the initial Phi endings of the MTA study, and others, with children that combined treatment was typically more beneficial than either medications or psychosocial treatments alone. This would seem to be the best approach for now, with both children and adults with ADHD, when both are available, something not usually the case in rural areas of the United States. Besides such feedback counseling about the disorder following the evaluation, ADHD medications, and the manual-based CBT interventions, some counseling of the teen or young adult with ADHD, along with his or her parents or guardians, is in order concerning other major domains of increased risk in major life activities associated with ADHD at these ages, as well as possible means to address the risks. Barkley and Benton, 2010, Ramsey, 2010. While little or no research exists on the best treatments for various impairments, some common sense advice can still be offered. These impairments include not only the driving problems noted above, but also the penchant for risky sexual behavior and adolescent pregnancy of Barkley, Fisher, et al., 2006, Flory, Molina, Pelham, Nagy, and Smith, 2006, occupational difficulties, money management problems, and increased health risks such as excess use of legal substances, psychosomatic symptoms, obesity, bulimia, in ADHD females, and cardiovascular disease, Barkley et al., 2008. It is also important to direct such patients and families to trusted sources of information on adult ADHD and its management in the trade media and on the internet. See Adler, 2006, Barkley and Benton, 2010, Perra, 2009, Sarkis and Klein, 2010, Tuckman, 2007. Given the plethora of such information in these sources, much of which may not be science-based. My remarks and caveats notwithstanding, Dr. Ansel has selected a Phi-NE case, representative of the typical referral that one is likely to encounter in seeing young adults for evaluation and management of ADHD. His approach to the evaluation, counseling, and management of the case is commendable, empirically based, and an exemplar to other clinicians. REFERENCES ADLERL 2006. Scattered Minds, Hope and Help for Adults with Attention Deficit Hyperactivity Disorder. New York, G. P. Putnam Sons. Attention Deficit, Hyperactivity Disorder, ADHD. 49. ANGOLD, COSTELLOE, J. and ERKANLIA. 1999. COMORBIDITY. Journal of Child Psychology and Psychiatry, 40, 57-88. B. RKLEYR. A. 2011A. The Barkley Adult ADHD Rating Scale, 4. New York, Guilford. B. 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 RKLEYR. A. 2011B. Barkley Functional Impairment Scale. New York, Guilford. RKLEYR. A. 2011C. Executive Functions, What They Are, How They Work, and Why They Evolved. New York, Guilford. RKLEYR. A. 2011D. The Barkley Deficits in Executive Functioning Scale. New York, Guilford. RKLEYR. A. and BENTON, C. 2010. Taking Charge of Adult ADHD. New York, Guilford. Barkley, R.A. and Cox, D. 2007. A review of driving risks and impairments associated with attention deficit, hyperactivity disorder, and the effects of stimulant medication on driving performance. Journal of Safety Research, 38, 113-138. B. RKLEYR. A. and FISCHER, 2011. PREDICT, INGIMP, IRMENTINOCCUP, ATIONALFUNCTIONING in hyperactive children as adults. Self-reported executive function, EF, deficits versus EF tests. Developmental neuropsychology, 36, 137-161. B. 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 RKLEYR. A. FISCHER, SMALLISH, and FLETCHER, K. 2002. THEP, RSISTENCEOF, ATTE Attention Deficit, Hyperactivity Disorder into Young Adulthood as a Function of Reporting Source, and Definition of Disorder. Journal of Abnormal Psychology, 111, 279-289. RKLEYR. A. FISCHER, SMALLISH, and FLETCHER, K. 2004. YOUNGADULTFOLLOW, UPOF Hyperactive Children, Antisocial Activities and Drug Use. Journal of Child Psychology and Psychiatry, 45, 195-211. RKLEYR. A. FISCHER, SMALLISH, and FLETCHER, K. 2006. YOUNGADULTFOLLOW, UP of Hyperactive Children, Adaptive Functioning in Major Life Activities. Journal of the American Academy of Child and Adolescent Psychiatry, 45, 192-202. RKLEYR. A. and MURPHY, K. R. 2011. THENATUREOFEX, ECUT, IVEFUNCTION, EF, DE5 sits in daily life activities in adults with ADHD, and their relationship to EF tests. Journal of Psychopathology and Behavioral Assessment, 33, 137-158. RKLEYR. A. and MURPHY, K. R. 2010. I'm PA, IRMENTINM, AJORLIFEACT, IVITIESA, and DADULT ADHD, the predictive utility of executive function, EF, ratings versus EF tests. Archives of Clinical Neuropsychology, 25, 157-173. RKLEYR. A. MURPHY, K. R. and FISCHER, 2008. ADHD in Adults, What the Sciences Says. New York, Guilford. I. L. DERMAN, J. PETTY, C. R. FRIED, R. BLACK, S. FANEUIL, A. DOYLE, A. E. SEIDMAN, L, J. And Farhan, S. V. 2008. Discordance between psychometric testing and questionnaire-based definitions of executive function deficits in individuals with ADHD. Journal of Attention Disorders, 12, 92-102. DERMAN, J. PETTY, C. FRIED, R. FONTANELLA, J. DOYLE, A. E. SEIDMAN, L. J. And FARAONES. V. 2006. I'm PACTOFPS, YCHOMET, RICALLYDE Phi NED Deficits of Executive Functioning in Adults with Attention Deficit Hyperactivity Disorder. American Journal of Psychiatry. 163, 1730-1738. IRR. J. R. PESCHARDT, K. S. BUDHANIS. MITCHELL, G. V. And PINED. S. 2006. The Development of Psychopathy. Journal of Child Psychology and Psychiatry, 47, 262-275. CONNERS, C. K. ERHARDT, D. And SPARROWE. 1998. Connors Adult ADHD Rating Scales, CARS. North Tonawanda, New York, Multihealth Systems, Inc. 50. Childhood Disorders. E. WARDS, F. VARKLEY, R. LANERIM. FLETCHER, K. And METEVIA, L. 2001. PARE Adolescent Conflicts and Parent and Teen Psychological Adjustment in Teenagers with ADHD and ODD, The Role of Maternal Depression. Journal of Abnormal Child Psychology, 29, 557-572. FARAONES. V. And BIEDERMAN, J. 1997. DOATTENTIONDE FICID Hyperactivity Disorder and Major Depression Share Familial Risk Factors. Journal of Nervous and Mental Disease. 185, 533-541. F. RYK. MOLINA, B. S. G. PELHAM, W. E. JR. GNAGY, and SMITH, D. 2006. CHILD ADHD predicts risky sexual behavior in young adulthood. Journal of Clinical Child and Adolescent Psychology, 35, 571-577. FOWLERT. LANGLEY, RICEF. WHITTINGERN. ROSS, K. VANGOOZENS. OWENM. J. ODONOVANM. C. VANDENBREEM. And THAPARA. 2009. PSYCHOPATHYTRAITSI in adolescents with childhood attention deficit hyperactivity disorder. British Journal of Psychiatry, 194, 62-67. GORDONM. ANTSHEL, K, FARAONES. VARKLEY, R. LEWANDOWSKIL. HUDZIAK, J. BIEDERMAN, J. And CUNNINGHAM, C. 2006. SYMPTOMSVE, RSUS, IMPA, IRMENT, THECASE. For respecting DSM-IV's Criterion D. Journal of Attention Disorders, 9, 465-475. HERVEY, A. S. EPSTEIN, J. N. And CURRY, J. F. 2004. NEUROPS YCHOLOGYOFADULTS WITH Attention Deficit, the Hyperactivity Disorder, a Meta-Analytic Review. Neuropsychology. 18, 495-503. J. HNSTON, C. And MASHE. J. 2001. FAMILIESOFCHILDRENWITHATTENTIONDE FICIT, the Hyperactivity Disorder, Review and Recommendations for Future Research. Clinical Child and Family Psychology Review, 4, 183-207. KOLLINSS. H. MCCLERMAN, J. And FUEMMELER, B. F. 2005. ASSOCIATIONBETWEE and SMOKING and attention deficit, the hyperactivity disorder symptoms in a population-based sample of young adults. Archives of General Psychiatry, 62, 1142-1147. KNOUSEL. E. And SAFRENS. A. 2010. CURRENTSTATUSOFCOG, ITIVEBEHAVIORALTHE, Adult Attention Deficit Hyperactivity Disorder. Psychiatric Clinics of North America. 33, 3, 497-509. L. WANDOWSKIL. J. LOVETT, B. J. And GORDON, M. 2009. MEAS UREMENTOFS YMPTOMS EVERI. YANDIMPA IRMENT. INS. GOLDSTEIN and J. A. NAGLIERIEDS, Assessment of Impairment, From Theory to Practice, pp 5-14. New York, Springer. LYNAM, D. R. 1998. EARLYIDENTI Phi-cation of the FL Edgeling Psychopath, Locating the Psychopathic Child in the Current Nomenclature. Journal of Abnormal Psychology, 107, 566-575. MCGOUGH, J. J. And BARKLEY, R. A. 2004. DIAGNOSTICCONTROVERSIESINADULT American Journal of Psychiatry, 161, 1948-1956. MOLINA, B. S. G. HINSHAWS. P. SWANSON, J. M. ARNOLD, L. E. VITELLO, B. JENSEN, P. S. EPSTEIN, J. N. HOZA, B. HECHTMAN, L. ABIKOFF, H. B. ELLIOTT, G. R. GREENHILL, L. L. NEWCORN, J. H. WELLS, K. C. WIGALT. GIBBONS, R. D. HUR, K. HOUCK, P. R. and the MTA Cooperative Group. 2009, MTA at 8 years, prospective follow-up of children treated for combined type ADHD in a multi-site study. Journal of the American Academy of Child and Adolescent Psychiatry, 48, 484-500. MURPHY, K. R. and GORDON, M. 2006. ASSESMENTOFADULTSWITH INR. A. VARKLEY. Ed. Attention Deficit Hyperactivity Disorder, A Handbook for Diagnosis and Treatment. 3 Road ED, pp. 425-451. New York, Guilford. Attention Deficit, a Hyperactivity Disorder, ADHD. 51. P. 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 RDINI, D. OBRADOVIC, J. And LOEBERR. 2006. INTERPERSONALCALLOUSNESS, HYPER Activity Impulsivity, Inattention, and Conduct Problems as Precursors to Delinquency Persistence in Boys. A comparison of 3 grade-based cohorts. Journal of Clinical Child and Adolescent Psychology, 35, 46-59. RAG. 2009. Is it you, me, or adult ADHD? San Francisco, California, 1201 Alarm Press. INCE, J. B. WILENS, E. SPENCER, J. And BIEDERMAN, J. 2006. PHARMACOTHERAPYFORADULT INR. A. BARKLEY, ED, Attention Deficit Hyperactivity Disorder, A Handbook for Diagnosis and Treatment, 3rd ed, pp. 704-736. New York, Guilford. RAMSAY, J. R. 2010. Non-medication treatments for adult ADHD, evaluating impact on daily functioning and well-being. Washington, D.C., American Psychological Association Press. RAMSAY, J. R. And ROSTAIN, A. L. 2007. Cognitive Behavioral Therapy for Adult ADHD, an Integrative Psychosocial and Medical Approach. New York, Routledge. ROTH, R. M. ISQUITH, P. K. And GIOIA, G. A. 2005. Behavior Rating Inventory of Executive Function, Adult Version. Lutz, Florida, Psychological Assessment Resources, Inc. S. FRENS. PERLMAN, C. SPRICHS, and OTTOM. W. 2005. Therapist Guide to the Mastery of Your Adult ADHD, a Cognitive Behavioral Treatment Program. New York, Oxford University Press. S. 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 RKISS. M. And KLEIN, K. 2010. ADD and Your Money, a Guide to Personal Finance for Adults with Attention Deficit Disorder. Oakland, California, New Harbinger. TTERFIELD, J. H. FALLER, K. F. CRINELLA, F. M. SCHELLA. M. SWANSON, J. M. And HOMER. L. D. 2007. A 30-year prospective follow-up study of hyperactive boys with conduct problems, adult criminality. Journal of the American Academy of Child and Adolescent Psychiatry, 46, 601-610. LANTO, M. V. 2010. Treating Adult ADHD, a Cognitive Behavioral Manual. New York, Guilford. NUGA, BARKEE, J. S. DALEY, D. And THOMPSON, M. 2002. DOESMATERNALADHD reduce the effectiveness of parent training for preschool children's ADHD. Journal of the American Academy of Child and Adolescent Psychiatry, 41, 696-702. TUCKMAN, 2007. Integrative Treatment for Adult ADHD. Oakland, California, New Harbinger. Washbush, D. A., and Willoughby, M. T., 2008. Attention Deficit, Hyperactivity Disorder, and Callous Unemotional Traits as Moderators of Conduct Problems when Examining Impairment and Aggression in Elementary School Children. Aggressive Behavior, 43, 139153. R. SPONSE. KEVINM. ANTSHEL. I am grateful to Dr. Barkley not only for his astute and insightful commentary, but also to have the opportunity to respond. Dr. Barkley is a veritable ADHD encyclopedia. There is no one, in my estimation, who knows the ADHD literature better than Dr. Barkley. It is a great honor to have someone so knowledgeable about ADHD comment on my clinical work. As Dr. Barkley clearly delineates, ADHD in adulthood is very rarely diagnosed without a comorbid condition. Substance abuse is one common comorbid condition, and Pat was required to complete a substance abuse treatment program with continuing monitoring of his substance use. Thus, my focus was more on the ADHD and associated impairments. However, I continued to frankly discuss Pat's substance use and the associated impairments. While I would not say that his marijuana use was the primary focus of our treatment, his marijuana use was an almost weekly discussion. My experience with Pat regretfully suggests that even with random drug tests, it is possible to continue to use marijuana yet pass drug tests. Dr. Barkley refers to the limited insight of those with ADHD. While not all individuals with ADHD have limited insight into their own functioning, a sizable number of those with ADHD may demonstrate a positive illusory bias. That is, individuals with ADHD may report that they are functioning better than they may actually be. As one parent of a high school student with ADHD recently told me, there is no one more surprised when he sees his report card than my son. He thought he was doing fine. I guess his teachers think otherwise. Although improved, Pat continues to have a relative lack of insight into his functioning. For this reason, ongoing contact with collaterals such as his mother have become part of my work with Pat. Dr. Barkley also astutely points out the relatively limited number of instruments that currently exist to assess functional impairments in adults. While I am excited about the new instruments that have been recently developed, and our clinic will be switching to those instruments for assessing impairment, at the time that I began working with Pat, these instruments were not available. I could not agree with Dr. Barkley more when he asserts that the focus should move well beyond symptoms and focus far more on functioning. The current move in ADHD pharmacological intervention studies is also in this direction. Attention Deficit, the Hyperactivity Disorder, ADHD. 53. Finally, Dr. Barkley also correctly notes that adults with ADHD may be impaired in their application of executive functioning skills. It is not uncommon for an adult with ADHD to score very well on psychological tests designed to measure executive functioning, such as the Wisconsin Card Sorting Test or Stroop Color Word Test, yet remain functionally impaired in the real world by his or her poor planning and limited attention regulation skills. Our clinic is currently in the process of moving away from these psychological tests as routine for our adult patients. Again, Dr. Barkley has suggested several self-report and collateral report measures that we are currently considering. In sum, I thank Dr. Barkley for his insightful commentary and agree with all of his excellent observations and suggestions. Treating individuals with ADHD, while undeniably challenging, can also be very rewarding. Anyone who has ever treated an individual with ADHD knows that ADHD is not the benign condition that it is often made out to be in the popular media. CASEHISTORY